everyone. My name is Olayinka Kasunmu, and I want to thank you all for joining us for the Tennessee SHIP and SMP Virtual Volunteer Conference. To all of our new volunteers, I want to give you a warm welcome to our Tennessee SHIP family. We are so happy to have you. To all of our returning volunteers, we want to say a continued thank you for your service with our program. We honestly would not be able to accomplish any of our goals without our volunteers' continued service. Without our 500 plus volunteers, we wouldn't have been able to serve over 117,000 beneficiaries in 2019, as well as save our beneficiaries well over $3.8 million, which is no small feat. As a reminder of today's agenda, we will start off with a welcome with the TCAD staff up here in Nashville. We will then go into a senior Medicare patrol updates with Loni. From there, we will go into our documents and trust section with Chris Johnson, and then we'll have a short lunch break followed by an optional yoga session. Afterwards, we'll have our dental benefits portion with Nicki from Smile on 60 Plus, and then we'll finish out with our closing remarks as well as a regional breakout session with your regional coordinators. To get us started, I just want to remind everyone of the new additions and changes to the Tennessee SHIP team. So we have our new state SHIP director, Ryan Ramsey. I know a lot of you are familiar with Ryan. He's been with the program for many years, and he's been such a great help to our operation, as well as we have Lori Galbreath. Lori joins the TCAD staff from GNRC, and she is the Program Development and Quality Assurance Coordinator for the state. There's me. I am the new SHIP Volunteer Program Coordinator for the state, and at Upper Cumberland, we have Amanda Smith. She is their new SHIP Outreach and Volunteer Coordinator, and over in Nashville with GNRC, we have Christine Mather, the Senior Medicare Counselor, as well as Shay Northfield, a Medicare Counselor. We're so happy to have all of these new additions to our family. So as we know, there's been a significant amount of changes, not only in staff, but in our operations. We want to commend all of our volunteers for being so adaptable with all the changes due to the COVID-19 pandemic. I know this year has been incredibly challenging, not only personally, but also with our program. So I really want to thank all of our volunteers for being so adaptable. As you know, we've officially switched from in-person counseling to virtual counseling. So in-person events of all sorts, including outreach, are all moving to virtual, which has been a big adjustment, but everyone has been so on board to making this change. So we really do appreciate it. And during our breakout sessions today, your AAAD staff will update you on your proceedings during the annual enrollment period this year. So depending on your area, your different coordinator will let you know which program and platform you'll be using to do virtual counseling and how you'll be able to assist and make sure annual enrollment goes as smoothly as possible. That is just a little bit of changes I have for right now. Next, we'll have Ryan Ramsey go over the updates from ACL and CMS. And give me just 1 second. Let me switch it over to Ryan.
Well, good morning, everybody. I'd like to just mirror what Olayinka said earlier. My name is Ryan Ramsey. I am the SHIP director for the state of Tennessee. Now, I was promoted to my position about 3 days into quarantine, so it's been a real whirlwind, and I can appreciate how much of a whirlwind it's been for all of you, and it's just sort of amazing to have such a great group of people who we get to work with every single day. As Olayinka mentioned, last year we helped people save over $3.8 million and served over 117,000 people, which is the most that we've ever served in the SHIP program. And that is totally thanks to you volunteers and to all the coordinators who come in every day and do such a great job and truly care about all of the beneficiaries in the state of Tennessee. And we could not have done any of this without you. And because this past year has been so crazy, I'm even more appreciative to have all of you, you know, working with me and Olayinka and Lori, because we have all been able to sort of overcome all of these hardships and barriers to serving our older adult population. And it's been just, while it's been very challenging and very frustrating, it's also been very rewarding to have so many people still doing such a great job. So I just wanted to say thank you and sort of follow up on what Olayinka said of how valuable you are to this program and to us. Today, I just wanted to go over a few of the current topics and updates when it comes to Medicare. First, we're going to go over some CMS priorities and some of their strategic initiatives. First and foremost are the exceptions and extensions for reporting requirements that they have put in place as a response to the COVID-19 pandemic. CMS has granted exceptions and reporting requirements to clinicians and providers participating in quality reporting programs, including a few of these things like the Quality Payment Program, Merit-Based Incentive Payment System, the Medicare Shared Savings Program, Accountable Care Organizations, End-Stage Renal Disease Quality Incentive Programs, Crown Web National ESRD Patient Registry and Quality Measuring Reporting System, Hospital-Acquired Condition and Readmissions Reduction Programs, Ambulatory Services Centers, Ambulatory Surgical Centers, Inpatient Psychiatric Facilities, and hospital inpatient and outpatient quality reporting programs. Another one is hospital and skilled nursing facility value-based purchasing programs, PPS exempt cancer hospital quality programs, and promoting interoperability programs for eligible hospitals and critical access hospitals. And then lastly is home health, hospice, inpatient rehabilitation facility, long-term care hospitals, and skilled nursing facility quality reporting programs. Essentially, they're allowing all of these programs to have exceptions and extensions in regards to when all of their reports are due throughout the year. We were granted that same extension with some of our reports as well. So CMS is just allowing people to submit reports later due to all of the barriers and hardships that we've experienced over this, and there may be a delay in information since we can all not be in communication as readily as we were prior to this pandemic. Some newer updated innovative models that they are rolling out are the Emergency Triage, Treat, and Transport model, or the ET3 model, the Value-Based Insurance Design Model Update, the Kidney Care Choice Model and ESRD Treatment Choices Model, and the Part D Senior Savings Model. The ET3 model is a voluntary 5-year payment model to allow beneficiaries to access the most appropriate emergency services at the right time and place. It provides greater flexibility to ambulance care teams to address emergency healthcare needs following the 911 call. What they will do is they will transport a beneficiary to an alternative destination, such as a primary care doctor's office or an urgent care clinic, or they will initiate and facilitate treatment in place by a qualified healthcare practitioner, either in person or on the scene via telehealth. The Value-Based Insurance Design, or VBID model update. The model was revised to include all 50 states and territories starting in 2020. Beginning in calendar year 2021, the VBID model will also test including Medicare hospice benefits in Medicare Advantage. The performance period of this model was extended by an additional 3 years all the way through 2024. And some models that are going to transform kidney care. Right now, the required model in proposed rule is the end-stage renal disease, or ESRD, treatment choices. the ETC. This would encourage the greater use of home dialysis and kidney transplants for people with Medicare. And the payment adjusted under this model would be January the 1st of this year, all the way through June the 30th, or the end of the fiscal year 2026. There are a few optional payment models that go with this, that being the Kidney Care First model, the Comprehensive Kidney Care Contracting Graduated, the CKC Professional, and then the Global Payment Model. Now, the Part D Senior Savings Model is the one that we've heard the most about through this year. This tests the impact of offering an increased choice of enhanced alternative Part D plan options that will offer a lower out-of-pocket cost for insulin. Part D sponsors will offer beneficiaries plan choices that provide broad access to multiple types of insulin, and this will provide a maximum $35 copay for a 30-day supply in the deductible while you're in the initial coverage and in the coverage gap phases of the Part D benefit. Under this model, beneficiaries should save an average of $446 in annual out-of-pocket costs on insulin, or over 60% of their annual out-of-pocket costs on insulin. They will provide improved access to and affordability of insulin in order to improve management of beneficiaries who require insulin as part of their care. Now, how this will appear on the plan finder, how these savings models will appear. We did become aware that not all of these Part D plans are going to be participating in this model. They can opt out of whether they wish to participate in the savings model. However, we will be able to see this on the plan finder. People with Medicare will be able to find a Part D plan participating in the Part D Senior Savings Model through the plan finder. The plan finder will include a filter to identify plans that will offer capped out-of-pocket costs for insulin under this model. People will be able to easily find those plans beginning at the start of the annual enrollment period from October the 15th through December the 7th. Now for original Medicare updates. There is going to be a new special Medicare notice for consumers turning 65. So people who are on a marketplace plan, this notice will be mailed to them. It will be mailed to all marketplace enrollees a few months before turning 65 to inform them about their Medicare eligibility and changing their health care coverage. It will inform them what the next steps of this process are going to look like, when they need to enroll in Medicare, and it will also include about keeping marketplace coverage if enrolled into Medicare, and also how keeping that marketplace coverage will affect their Medicare going forward. A new model as well, change to opening to the original Medicare will be the equitable relief from late enrollment penalties. If you have had premium-free Part A, but not Part B on or before June the 30th, 2020, you may have a special opportunity, which is called equitable relief, to sign up for Medicare Part B without any late enrollment penalty. If you meet the eligibility criteria, you can request this equitable relief even after June the 30th, 2020. You just had to have been eligible for it on or before June the 30th, 2020. However, they will allow you to request it after that point. You should visit your local Social Security office or call the office at 1-800-772-1213 to request removal or reduction of their Part B penalty. And you must show your Medicare notice or other forms of acceptable documentation to ensure that you can qualify for this. Now, we don't have all the information on what that process is going to look like. However, I will be reaching out to our contacts with Social Security here in the near future. And just as soon as we get a better picture of what that entire process is going to look like and what we can do to help beneficiaries ease that process, we will get a documentation made on that and send that out to everyone. Medicare enrollment numbers. This is not anything that is pertinent or anything that we have to know. I just find it to be very interesting, and therefore we included it on here. As of June of this year, over 37.5 million people were enrolled into Original Medicare, and just under 25 million are enrolled into Medicare Advantage or other health plans, bringing the total of Medicare enrollees to about 62.5 million beneficiaries. It does show enrollment size based off of state, but it is very interesting to see that Original Medicare still is the largest enrollee for people nationwide. However, Medicare Advantage is making a rise, and so, you know, after this year, we'll be able to see how these numbers change and see if all the extra money spent into all of those Joe Namath commercials are going to have any effect on Medicare Advantage enrollment numbers. The initial enrollment reminder notice. This is something that the three of us were really impressed with and think that this will be an excellent help to all of the Medicare beneficiaries. This will be an additional letter that will be mailed out as a part of the initial enrollment period, or the first time that somebody becomes eligible for Medicare. It will follow the packet that's normally sent out to people who are auto-enrolled into Parts A and B of Medicare living in the U.S. or U.S. territories. Where that first packet is sent 3 months prior to the month that they turn 65, this one will be sent the month before their Medicare coverage will begin. What will happen is it will remind people to learn about Medicare, to review their benefits, and to make their coverage choices. It will also remind them, hey, here's your timeline. You need to, you know, take care of all of these things prior to this date so you can make sure and have your benefits start when your Medicare starts. And these are set to be starting to be mailed out late this year. If they have not already begun being mailed out, they will be mailed out starting within about the next month or so. New tips in the Medicare and You Handbook. Starting in 2021, the Medicare and You Handbook will include new tips for those who are new to Medicare. These new tips will include things to do now, like deciding on extra coverage and benefits, things to do within the first year, like learning what Medicare covers, and opportunities to make coverage changes outside of the initial enrollment period. This also is going to be very helpful for a lot of people and will probably cut down on how many people call us looking to switch plans when they don't have any special enrollment period. It will make things a little bit more clear to everyone when and when not they can make changes to their coverage. Another thing that's going to be a big change is online premium payment. There's going to be a new option for that. CMS has launched an online payment by credit and debit cards or directly from savings or checking accounts through a bank's online bill payment service by using a beneficiary's secure account on mymedicare.gov. They will be able to pay Medicare Part A, Medicare Part B, or Medicare Part D IRMA premiums online. They will not be able to pay their prescription drug plan or Medicare Advantage premiums through this service, but they will be able to pay that prescription drug IRMA if their tax return from 2 years previous puts them in a high enough income bracket that they will have to pay that income-related adjustment for their prescription premium there as well. However, people can set up a automatic direct billing through their Medicare Advantage or Part D prescription drug plan company, so they will be able to still do that as well. So if somebody so chooses, they will be able to have all electronic payment taken care of. You will get a confirmation number when you make your payment, so you can keep track that, yes, you did in fact make your payment, and CMS did notify you that that payment has been received. And your credit or debit card statement will show a payment made to CMS Medicare. Now, there are therapy caps for 2020. The Bipartisan Budget Act of 2018 repealed therapy caps. An annual dollar limit, $2,080 for this year for 2020, for physical therapy and speech language pathology combined, and $2,080 for occupational therapy. The limit remains as a threshold above which claims must include the KX modifier as a confirmation that services are medically necessary, just as it was before. It retains the targeted medical review process, but at a lower threshold amount, or $3,000, instead of $3,700 through 2028. We also have the new opioid treatment program benefit. Medicare Part B will now cover opioid use disorder treatment services provided by opioid treatment programs, or OTPs. You pay nothing for these services if you get them from an OTP that's enrolled in Medicare, and the Part B deductible applies. Services include medication-assisted treatment, counseling, drug testing, and individual and group therapy. Counseling and therapy services are covered in person and by virtual delivery. The new benefit establishes Medicare's coverage of methadone for the first time, in addition to coverage of buprenorphine. Sorry, I'm sure I mangled that. That was already covered. During the COVID-19 public health emergency, counseling and therapy services, as well as periodic assessments, will be covered if rendered by telephone. Now, this is another big change as well. Medicare is now going to be offering an acupuncture benefit. Medicare Part B, which we all know covers our outpatient coverage, our medical insurance, covers up to 12 acupuncture visits in 90 days for chronic low back pain. Chronic low back pain is defined as having lasted 12 weeks or longer, having no identifiable systemic cause, or not associated with metastatic, inflammatory, or infectious disease, and pain that's not associated with surgery or pregnancy. An additional 8 sessions will be covered if you show improvement, but no more than 20 acupuncture treatments can be given yearly or annually. If your chronic low back pain isn't improving or is getting worse, then treatments will cease to be covered. They won't be covered at all at that point. Home health patient-driven grouping models, or PDGM. The BBA of 2018 included several requirements for home health care payment reform, effective January the 1st of this year. It was designed to focus more heavily on clinical characteristics to better align Medicare payments with patients' care needs. Change from 60-day episodes of care to 30-day periods of care. There will be an elimination of therapy thresholds, the number of therapy for use in determining home health payment, and will assign 30-day periods of care into one of 4-3-2 case mix groups based on a number of variables. These variables being timing, admission source, clinical group, functional impairment level, and morbidity adjustments. Prior authorization process and requirements for certain hospital outpatient department or OPD services. Beginning July the 1st of this year, certain hospital outpatient department services required prior authorization as a condition of payment. Many injections, rhinoplasty and vade ablation are listed in those conditions that will require prior authorization. Medical necessity documentation requirements remain the same, and hospitals will receive a decision within 10 days. Unlimited resubmissions of prior authorization requests are allowed, but these related services performed in a hospital may also be affected, which include, but aren't limited to, anesthesiological services, physician services, and facility services. And depending on the timing of claims, submissions for any related services or claims may be automatically denied or denied on a post-payment basis. So this is something that we're going to have to be very careful about in the upcoming year, because this does seem like it's going to be a very tricky tightrope to walk down for a lot of Medicare beneficiaries, that they're going to have to make sure that they're getting prior authorization within the correct number of times, that they know that they can resubmit that as many times as they need to, but they also need to submit that at the right time to get the most out of their care that they possibly can. And Medicare virtual services. There are going to be three main types of virtual services physicians and other professionals can provide to people with Medicare, those three being telehealth visits, virtual check-ins, and e-visits. Now, virtual check-ins are Medicare paying for a virtual check-in for payments to communicate with their clinician and avoid unnecessary trips to the clinician's office. They're provided in all areas, not just rural, and provided via a number of communication technology modalities, including telephone or exchange of information through video. CMS expects that these virtual services will be initiated by the patient, and that the patient must verbally consent to receive virtual check-in services. The Medicare coinsurance and deductible would generally apply to these services. These are going to be, mostly the sort of informal check-ins, and are going to be sort of like a overall, like, sort of like an annual physical type of visit. They're not going to be as in-depth as, say, some of these e-visits may be. Payments will communicate with their clinicians without going to the office by using online patient portals. This is not only limited to rural settings and no geographic or location restrictions. You can e-visit with your doctor anywhere. These services can only be reported when the billing practice has an established relationship with the patient. You must have a relationship with that patient, not just be billed for some random person who is trying to contact a patient. The individual services need to be initiated by the patient. However, practitioners may educate beneficiaries on the availability of the service prior to the patient initiation. And then the Medicare coinsurance and deductible would generally apply to these services as well. New telehealth services for substance use disorder treatment. Medicare telehealth benefits for treatment of a substance use disorder or a co-occurring mental health disorder for services furnished on or after July the 1st, 2019. This removes the originating site geographic conditions for payments and adds an individual's home as a permissible originating telehealth services site. So they will be allowed to use their home as an originating service site for these telehealth services. And it requires that no originating site facility fee will be paid in instances when the individual's home is the originating site. Practitioners would be responsible for assessing whether individuals have an SUD diagnosis, substance abuse diagnosis. The expansion of telehealth services during COVID-19 public health emergencies, like we stated just a second ago, a lot of these telehealth services have been expanded and extended through this pandemic, effective as of March the 6th of this year and for the entire duration of this pandemic. People with Medicare who are at higher risk for COVID-19, meaning that they're above a certain age and have other disabling conditions that would lead them to be in a higher risk category, are able to visit with their clinician from their home without having to go to an office or hospital, which puts themselves and others at risk. People with Medicare can receive a specific set of services through telehealth, including evaluation and management visits, common office visits, mental health counseling, and preventive health screenings. Medicare can pay for office, hospital, and other visits furnished via telehealth across the country, and including in the patient's place of residence. So they could go to a facility and then receive that telehealth at the facility, or they could even get that telehealth straight from their own home, and Medicare will pay for that. Medicare Advantage updates. They are going to be expanding health-related extra benefits in Medicare Advantage. An item or service is going to be considered primarily health-related if it's used to diagnose, prevent, or treat an illness or injury, compensate for physical impairments, improve the functional or physiological impact of injuries or health conditions, or reduce avoidable emergency and healthcare use. The benefit must focus on an enrollee's healthcare needs and be recommended by a licensed medical professional as part of a care plan, if not provided by one. Now, this is something that I've fought against as well, is that they're going to be using the term supplemental benefits a lot when it comes to Medicare Advantage. I know that that's been a big thing that we've been fighting for a number of years, is the term supplemental, and people using that to refer to many different things aside from Medigap policies. When we were told that they were going to be using supplemental benefits as a sort of placeholder for non-medical benefits, I did express that we felt that that would be confusing for many beneficiaries and would only lead to more improper understanding of Medicare. However, there seemed to be no agreement from CMS, and when I was on the call with multiple other SHIP directors from across the nation, no one really felt the same as I, that this was going to be sort of a really big issue. However, I still believe, and I believe that most of you agree, that the use of supplemental benefits is something that we're going to have to sort of watch out for in terms of our beneficiaries' understanding of their benefits. But these Medicare Advantage plans may offer additional benefits that are not primarily health-related benefits to enrollees who are chronically ill enrollees. And when the additional benefits have a reasonable expectation of improving or maintaining the health or overall function of the chronically ill enrollee. Some of these non-health related and, in quotation marks, supplemental benefits for the chronically ill that are non-primarily health related items or services are things like home delivered meals, food and produce, complementary therapies, transportation for non-medical needs, services supporting self-direction, structural home modifications, pest control, indoor air quality equipment and services, and general supports for living, as well as social needs benefits. These are excellent services, and I am glad to hear that Medicare Advantage is going to be including things like this. Just the term supplemental should be taken out and instead put, non-primary health related or just non-medical benefits. Expansion of telehealth benefits in Medicare Advantage. Effective this year, Medicare Advantage can include additional telehealth benefits beyond what Medicare allows in their bids for basic benefits. And Medicare Advantage enrollees may get Part B healthcare services from places like their homes rather than a healthcare facility. Medicare Advantage plans have broader flexibility in how they pay and expand telehealth services. So how they will pay and what services they will provide will differ from plan to plan, much like they do now. And then plans with low enrollment. Plans with low enrollment in existence for 3 years or more cannot renew for plans in 2020. These will be non-special needs plans that had fewer than 500 enrollees, special needs plans that had fewer than 100 enrollees, and will exclude plans with low number enrollment operating in service areas that don't have a sufficient number of competing options listed in Section 1876, cost plans, employer plans, or MSA plans. And then upon receipt of CMS notification, organizations will confirm each of the low enrollment plans will be eliminated or consolidated, and they will provide a jurisdiction for CMS renewal as well. And then this is another thing that's going to have a big effect for the positive stage, is starting January the 1st of next year, people with end-stage renal disease may join a Medicare Advantage or a Medicare Advantage prescription drug plan without the restrictions that are listed below. So these are the current restrictions that will be lifted as of January the 1st, 2021. You can join a Medicare Advantage plan only in certain situations if you have ESRD currently. You can join if you are already in a Medicare Advantage plan when you develop ESRD. If you're in a Medicare Advantage plan and the plan leaves Medicare or no longer provides coverage in your area. If you have an employer or union health plan or other health coverage through a company that offers one or more Medicare Advantage plans. And if you're medically determined to no longer have end-stage renal disease, for example, you've had a successful kidney transplant, you may be able to join a special needs plan that covers people with end-stage renal disease if one is available in your area. All of these will be ended, and then people with ESRD will be able to join a Medicare Advantage plan with or without drug coverage starting next year. And then they are going to add a few special enrollment periods for exceptional conditions. CMS will implement through sub-regulatory guidance as exceptional circumstances for these following things. A special enrollment period for employer or union group health plan elections. So if your company is coming up on their health plan enrollment period, or where you get to elect whether you're going to take whatever portion of your employer's health plan, then you would receive a special enrollment period during that time. A special enrollment period for individuals who disenroll in connection with a CMS sanction. So if CMS had put a sanction onto a plan and you decided to disenroll, then you would be gifted a special enrollment period in that point. Or a special enrollment period for a government entity declared disaster or other emergency. You would think that that would mean national disaster and would probably also carry on to a disaster such like that we're seeing now. If we have another gigantic health emergency within our country, you would think that that will extend onto something like that as well. Two new special enrollment periods, individuals enrolled in a plan that has been identified by CMS as a consistent poor performer. If you find that you're in a plan that has been deemed a consistent poor performer, you would be given a special enrollment period. And individuals who enrolled in a plan that's placed in receivership, essentially that plan owes money to CMS and does not have the ability to pay that. If they're put in receivership, then they CMS is going to be giving everybody a special enrollment period with that. And then we've got prescription drug coverage updates. I am going to turn this over to Lori so she can give you updates on those prescription drug coverages right here. So if you'll just hang on one second, I'll turn you over to Lori. Al.
Okay, go ahead. Okay, we are going to talk about the prescription drug coverage Part D update. We are going to get to the next slide. Okay, so we're going to talk about the true out-of-pocket cost or the TROOP updates for this year. TROOP does include all of your out-of-pocket costs that a person's going to pay, whether it's their deductible, their co-pays, anything that they pay during the coverage gap, and also anything that has been paid on your behalf. For example, like drug manufacturers, discounts, and things like that. They will cover that as well. So we can see that there's some changes this year. The initial deductible is actually going to be increased by $10 to $445 this year, this coming year, and the initial coverage limit is going to increase from $4,020 to $4,130 for next year, which will leave the total out-of-pocket threshold or TROOP going up to $6,550 for next year. Once you do reach the threshold, you get catastrophic coverage level, and you will only pay a small copayment, and that is either 5% or $3.70 for generics or $9.20 for brand name, and it's whichever is greater of those two, whether it's the 5% or the dollar amount. This year, another change that's going to be in place is the explanation of benefits is going to show your TROOP cost to date, so you'll be able to keep up with that better. And also, the TROOP is going to be able to transfer if you switch plans during the year, so you're not losing that benefit and anything that you've already paid in. So people with LIS who has the ability to change multiple times throughout the year, they're not going to lose the money that they have paid into the system. Okay, so this chart, I thought it was going to be very useful. It does give a little bit better breakdown of that deductible, the initial coverage period. It talks a little bit more about what they call the former coverage gap or the donut hole. Unfortunately, I think they used a little bit of bad language when they said that it was going away. It really didn't go away, but they consider it closed at this time, where you pay 25% for both generic drugs and brand name drugs. So it can cost a bit more money during that time, but it's not going to be 100% like it used to be. So one of the things that I wanted to talk about with that is the donut hole discount, because they do offer a discount. Part D enrollees are actually going to be receiving a 75% donut hole discount on the total cost of their brand name medications purchased while in the donut hole. Unfortunately, it's not going to cover those generics, but at least with any brand name medication, they will get that discount. The discount includes that 70% discount paid by the brand name drug manufacturer and a 5% discount paid by the Part D plan that they're in. The 70% paid by the drug manufacturer combined with the 25% you pay counts toward the troop. So you will get all of that credit, even the amount that the drug manufacturer pays for you. So for example, if you reach the donut hole and you purchase a brand name medication that has a retail cost of $100, you're going to pay $25 for the medication and then receive a $95 credit toward meeting your troop for the year. So some of the changes for the benchmark. Benchmark is actually going down in Tennessee this year. It's going down to $30.21. But unfortunately, those extra help copays are going to be going up. So generic copays will be $3.90 this year, and then the brand names are going to be $9.20. This is really important because, of course, we know people don't always read their mail, and they may miss those notices that they are going to get those increases. So for the first probably couple of months of the year, we will probably get those calls from people who are on LIS that their copays have gone up and they don't know why their medicines are so much more expensive to pick up. Just be diligent with them and educate, and just be reassuring that it is normal, that the cost did go up this year, and that their LIS is still working for them. So one of the things that not so great with this new, some of the limits they're putting on medications, Part D sponsors can exempt a formulary tier exemption, a medication from that exemptions process. If they put a medication into that specialty range, unfortunately, they will not do a tier exception. So we all know that those specialty meds tend to be more expensive because you end up paying a percentage instead of a dollar amount or a set copay. So it can be rather expensive during that time. And it can be, this is probably going to be a not so great thing, but they are putting a threshold cap on what they can charge. So $670 is the specialty cap for the full cost of a 30-day supply. So $670 is a lot for a lot of people, so that can definitely be a hardship. So you may just want to be, just know that they're going to be doing that. So I am going to be doing, I want to go over some of the changes to Plan Finder because there are quite a few changes this year, and we are going to be doing a quick Plan Finder demo. So I'm not focusing on doing the entire Plan Finder. I'm not going to go into a whole lot of depth since you guys are familiar with the Plan Finder, but I am going to go over and show you some of the changes that have occurred. So if you will, just give me a few minutes to change over and we will start that demo.
The Plan Finder demo, I'm just going to do the updates. I'm not going to go through a whole spiel on the Plan Finder. If you guys feel like you need that, get in touch with me and then we can do something later. But right now we're just going to go over the changes. So let me click on my link here. So we are now, can everybody see my screen as far as the Oh, no screen. Should be that one. Great. Awesome. I'll learn this one of these days. So it'll come to me. All right. So this is the Medicare.gov site. Everybody is familiar with it. They have kind of done a new thing where they're trying to get everything toward the top of the page now, so everybody can kind of find it. So they have got a new link up, preview the 2021 plans. If you just click on that, it will take you directly to the Plan Finder tool. What we're going to do today, we're not going to do an account or anything like that. We're just going to continue without logging on so I can kind of show you some of the changes that's been on here. One of the big things that has changed is they have added, when you do a search for the Part D and the Medigap policy, they have added that new Medigap tool. We are familiar with the CSI actuarial group. We've been using that all along, but they added it into the Medicare.gov page now. So you can actually go into that and do a Medigap comparison from this page. We're not going to do that today. We're going to just look at drug plans. And I am going to just enter my own zip code because I know it. It's familiar. So we are just kind of go through some of the things that they have changed. But this is not changed. So I'm going to put on here, I don't get any help. We do always want to look at our drug costs. I hate that question. It's kind of goofy, but anyways, how do you normally fill your prescriptions? It is filled, you can put both on here. It is going to give you, one of the changes they made is that they are going to give you the option of adding a mail order pharmacy later. So I'm just going to put in retail pharmacy at this time. We're going to go in next, and I'm just going to put in a couple of medicines. I have a list of them that I wanted to put in because I wanted to show you a couple of them. So with the, we'll just put in albuterol, add the drug. So this is an inhaler, and we normally see this. People want to only fill it maybe once or twice a year. And one of the changes that they did this year was you can actually put in every 2, 3, 6, or 12 months. So if they only get one inhaler a year, you can put in that one inhaler a year now. That is a really awesome change because it would give an inflated amount before. So they had to kind of subtract some of those medications because they didn't fill it every month. So we're going to add that one. I'm going to also add one of the medications that are on the insulin list. So the Basaglar is actually one of the insulins that are on the covered insulins list for the Part D savings model. I'm going to go ahead and add that one. I'm just adding the normal thing, and then I want to put in one more, and I'm going to put in a brand name just because I want to check to see how they're covering the brand name medications. So I'm just going to use the basic dosage that pops up. I'm going to say done. So one of the next changes is you can choose up to 5 pharmacies. So I'm just going to go through, I'm going to add mail order because I decided, maybe the mail order might be a cheaper option. So I'm going to click that. But then I can add up to 4 more. So I'm going to put in Walgreens, Kroger. Maybe I'm shopping around. I'm new to the area, so I want to see One of my close by pharmacies is Walmart. Another thing that is good that they have changed is that you can actually type in the pharmacy if it's not on those top 10 or 5 or however many they put on there. You can actually just go in and pick that pharmacy. So if they have a specific pharmacy, you could just type in the name of that pharmacy and pull it up, and it's a lot quicker. So you add those. Then another good thing is that they sort it now by lowest drug and premium costs, because all of last year we actually had to go in and change it to that option. So that was not a default search, but they've changed that to the default search now. They have added some filters that you can add in. One of them being the insulin savings. If you wanted to find out which plans are participating with the insulin savings plan, you can click this little box up here that says insulin savings, and it will show you those plans specifically. It does give you a breakdown on the, I'm going to go ahead and apply those filters. So we're looking at this first plan. It gives you your monthly premium. They've changed these little drug cards, what they call cards, plan cards, to show more information on this first page so that you can actually see your costs, your yearly costs, what your deductible is. Everything is on here as it is. I'm going to click on plan details to give you a little bit more information. So it does tell you now which plans of the pharmacies that you picked, which ones were preferred, which ones are standard. Unfortunately, it still does not give you the preferred pharmacies from the beginning of the plans that you just kind of have to go into each one and kind of look to see which of the ones that you chose. The good thing is you're choosing 5 pharmacies, so if none of them are preferred, you can actually go in, and there's a button now, you can change pharmacies pretty easily from here. So if you find none of them are preferred, or you pick some non-network pharmacies, you just go in and change your pharmacies pretty quickly with a click of a button. Then it comes down and it tells you a breakdown at each of the pharmacies where you're actually going to see your best cost. So CVS, it looks like 2203 gives you a monthly breakdown. So it does not sort it cheapest to as far as inside the plan details. It doesn't sort it, so you have to kind of go through and see which of the pharmacies was cheapest. Fortunately, that's on that first page, so you can actually scroll down to know where to look. But you see the basic LAR, it's $35 across the board. And after the coverage gap, it is actually cheaper. I have done a comparison where I've actually seen the $35 and it be more expensive in the coverage gap. So that's going to be kind of an interesting thing to see later on, to see what triggers it to be more expensive. I don't know why it would be. But yeah, that is the breakdown there. I want to go, one more thing I want to show you that has changed. You can actually go, if they decide they want to look at Advantage plans, you can click on the Advantage plans and look here at the plans that are available. Again, you can go into filter plans. They've added some things here. Say, for instance, a person is saying, well, I really want dental coverage, or I really specifically want a PPO. I don't want an HMO. You could set it to include drug coverage, so you're not getting shown those plans that don't have drug coverage, because I know a lot of people were signing up for that Humana Honor plan because it was popping up as cheapest for people. course, it didn't cover any medications. So unfortunately, there were some people that had to get changed out of that. Again, you can pick that insulin savings button so you can actually see plans that are going to give you that $35 copay. So it'll tell you the same information. It gives you your yearly cost. It gives you a breakdown of plan benefits so you can actually see, and you can actually see more if they offer any of those extra additional benefits for those chronically ill people. It'll show you that as well. Gives you your basic copays, and then it, of course, into the plan details, it goes into a little bit more detail. One of the things that they have added, of course, with the 2021 plans is the dialysis services. You'll see how much they have to pay out of pocket. Most of the plans that I have been seeing is 20%, which is the same thing as Medicare. But then, and then some of them are also requiring a prior authorization for that. So you're going to have to check into it to see what the plan asks. If you have people asking about that, that's going to be important to know to check into that. But it is listed under the other services tab on the plan. And something you may want to consider with the people who are on dialysis, because they're going to be new to Medicare Advantage plans, you may want to talk to them about maybe looking at plans with lower out-of-pocket maximums, because looking at the cost of dialysis, 20% is going to be a lot, and they are going to reach that out-of-pocket maximum pretty quickly. So if it's a really low out-of-pocket maximum, then of course everything's covered at 100% after that. So that would definitely be a beneficial thing for them. So we are going over a little bit. So I want to, let me check to make sure. Yeah, I think I have covered everything on my end. We will go ahead and let me get out of this, and I am going to pass the ball. Let's take about a 5-minute break while we get everything situated. Go to the bathroom, grab a drink of water, and we will see you back here at about, see, it's 10:13. So about 10:17, 10:20, we'll be starting back up. So we'll go ahead and take a break.
So I got it.
Okay, well, I hope everybody's back. This is Loni Holloway Hitchcock. I'm with the Tennessee SMP. I'm the program coordinator for the state. Most of you do know me. So what I'm going to be talking about today is the Tennessee SMP program. So here is our 2019 official Office of Inspector General report that we do every year. We had 379 active team members who worked over 20,000 hours. We had 802 group and outreach events who reached over 82,000 people. Number of individual interactions, that's the one-on-one, we had over 36,000. Cost avoidance on behalf of Medicare, I saved people, I know it's not a whole lot, $1,582. I did get back for a beneficiary $415.60. So that's pretty much what happened all of 2019. And these are official results that the Office of Inspector General put out in, I think it was June. So how can we improve those numbers? Just to make sure that on the client contact forms that you are, or the PAM forms, make sure you're marking Medicare fraud and abuse anywhere on that form. So please make sure that you're marking those. That's in, if you mention anybody, please make sure, Don't give out your Medicare number to anyone that calls you on the phone, these unsolicited phone calls. If you hand out like anything, brochures, if you hand out any of the S&P brochures, any of the healthcare journals, flyers, anything with S&P on it, please make sure you're marking the Medicare fraud and abuse on it so S&P can get credit. So also a thing that on the top of the form, of the client contact form, it's good if you check yes to send it to S&P, because if you're entering it in stars, you have to click that yes to send to S&P in order for it to count. This helps keep track of everything. It's that way we don't have to enter it twice. So it's really good thing that our systems actually talk to each other. So that's really one way how we can keep track of everything. So like I said, at the top of the beneficiary contact form, it says, send to S&P. Make sure you're clicking yes. Another way is to make sure you have your CSRS ID. These are generated in my CSRS system, so we need to make sure all the coordinators. I try to make my best to make sure all the coordinators have your CSRS IDs, so that they can automatically, go over. And again, under any of the different topics, if you all click fraud and abuse, any of the, because fraud and abuse is pretty much almost under any section in there. Make sure you click, fraud and abuse and something in there so it can be transferred over to the CSRS system. So this is one way how we can improve our numbers. So also, I've actually started the S&P Facebook page has been up for a while. I'm just trying to get as many, likes as I can. So please, put this out there, go on like the S&P page, because I put a lot of things on there. I share a lot of things, especially with, like the scams that are coming out. Anything from the OIG, I usually put on there. There's stuff from Medicare I put on there. There's stuff from the CHIP Resource Center I put on there. So I share a lot of stuff on the Tennessee S&P page. So please go and like the Tennessee S&P page. I'm trying to get, 1,000 likes. So please pass it along, share it to anybody and everybody. Also, I put a lot of tips on there I share a lot of things like that. So it's a really good page, plus it has my toll-free number, it has the email address, has everything. So people can get in contact with me if they have any, fraud questions. So please go like the Tennessee S&P Facebook page. So on to current scams. There is several different scams going around, as you all know of, or at least I hope you all know of. There is the COVID-19 scams. There is the Medicare brace scams that's going around. There's a Social Security scam going around and an IRS scam going around. So there's several different scams going around. So I'm going to be talking to you all today about those different scams. So some of the COVID-19 scams that are going around, there's some of the scammers are sending faxes to doctor's offices requesting, the doctor's signature for a COVID, test kit or an N95 mask, things like that. So they're those, and we've actually reported those. There's the free virus test kits in exchange for a Medicare number. So they're, the posers are, the scammers are calling Medicare beneficiaries saying, hey, we can get you a free virus test kit if you'll give us your Medicare number. Anything related to COVID-19. There's one, it's not happened in Tennessee, but I just thought I'd get it out there that there, calls claim to be from a grandchild or whatever, and they're stuck in, whatever city because of the virus, and they need money or whatever to stay in a hotel or whatever they might say. Some of these unauthorized test kits sold online. Make sure if you really need tested for COVID-19, there are several free testing stations throughout the state. You can go to your local health departments. You can go to your doctor. You go to the hospital. I mean, there's out there. You really don't have to get the test kits at home unless you really want to. But if you do, talk to your doctor and have your doctor order them. At home, any of these test line, just need to be wary of those. Some scammers are pretending to be COVID-19 contact tracers. Normally the contact tracers, they're just there to let you know that you've been in contact with someone that has been COVID-19 positive. They will not ask you any other personal information. For example, Medicare numbers, Social Security numbers. They won't ask you any of that. They might ask you who you have been in contact with in those days so that they can continue, tracing everybody. They'll also ask, usually if it's a contact tracer, they'll ask you to go get tested. And they'll tell you where the testing stations are. The scammers are selling fake cures online or social media. Facebook, you name it. You really can't trust anything out there, especially where it says there's a cure for COVID-19. There's not been a cure for COVID-19. So if those are out there, please be wary of those. People are receiving like emails, text messages. Some of those are, the fake contract tracers. Some of them are asking people to follow links. So I just make beneficiaries, especially you all volunteers and beneficiaries, aware that all these scams are out there. Just to be careful of what you're doing. Make sure the emails that you're getting. If it's not something familiar, don't click any links or anything like that. Same way with text messages, because this is how the viruses get started. The computer viruses get started, I should say. So that's how they send malware and things like that in some of these, and they can steal data and stuff like that. So just be wary of anything in these emails, anything that you get. Check them out before you ever click on anything. Of course, the brace scam, it has not slowed down whatsoever. I just got a call yesterday where this lady just got a box of braces, showed up on her doorstep. This is, it has not slowed down for this brace scam. There's callers claiming to be from Medicare that you can get free or low-cost braces in exchange for a Medicare number. The scammers are sending faxes to doctors' offices for signatures for braces. Boxes are just showing up at people's houses, and they're not, where their primary care physician hasn't prescribed or anything. Any other doctors haven't prescribed anything. So please, if you all are aware of any of these scams, please let me know. Get me in contact with that beneficiary so I can get as much information as I can. Because it's just never ending with this brace scam. I tell beneficiaries all the time, and I know everybody is getting bombarded with calls, the scam calls especially, and they're wanting to know how to stop them. And I tell beneficiaries, if you don't recognize the number, especially if you have caller ID and you don't recognize the number, don't answer it. Scammers are spoofing local phone numbers, so it looks like they're calling locally. So, hey, you're more likely to answer it because, hey, it's a local number. They're spoofing those numbers, so you're more likely to answer. And then, they're calling, claiming to be from Medicare or whatever, and they need your Medicare number so they can send you this free brace or whatever. I've been telling beneficiaries, just hang up on these calls. If you don't recognize the call, even if it's a local call, just hang up. The scammers will not leave you a message. Most of the time they don't. There is some, the IRS scam that's going on, I'll talk about here later. They actually leave a message. But please do not give your information out over the phone to anyone in these unsolicited phone calls. And I keep saying unsolicited because I know with annual open enrollment coming up, we're going to be calling people for, calling them back because they've sent in, their Part D worksheets. So we're going to be calling these people back. That is really not an unsolicited phone call because they have sent us a worksheet and telling us how they want to be contacted. So they should not count that as an unsolicited contact. It's these unsolicited, unknown phone calls that they need to watch out for. Also, with us having to do the callbacks and stuff like that, the Part Ds, we're not doing any face-to-face. Beneficiaries just need to be aware of, when we're talking to the beneficiaries, we need to make sure that we know that they know that we're with SHIP. This is my name. This is the SHIP I'm with. I'm a SHIP volunteer with the, whatever agency you're with. Just to make sure that, the beneficiaries feel more comfortable and things like that. Give your full name, give your, I'm with this agency, I'm volunteer with this SHIP, with this agency. So just make sure that, you're crossing those dots off. So the Social Security scam I was telling you about. Everybody's getting these. Your Social Security number has been used fraudulently in Texas or wherever, and there's a warrant out for your arrest. And if you don't call this number back, then they're going to come arrest you, or whatever they might say in this lovely message that they left. Because I got one not too long ago, and I just laughed through the whole thing. I actually answered the phone number. I laughed through the whole thing. But of course, and I hung up on them. Of course, I tried to tell them what I did, but but these actually don't need to be reported to me. So these scams I do not really handle because I just give everybody the Social Security Administration, their Office of Inspector General number. This is where they need to report these calls to. So if you get on any of these, here's the toll-free number. It's 1-800-269-0271. So that's where anybody needs to report these Social Security scams to. And so there's a couple of variations on it. Of course, they're always, there's something wrong with their Social Security, anything like that. So if it's truly something wrong with their Social Security, they don't need to call the number that was left. They need to look their Social Security number, their local Social Security Administration number up and call them to see if there is something wrong with their Social Security. Social Security they won't cut off anything, cut off money or anything like that unless, somebody's been charged with fraud. Anything like that, they don't cut off Social Security benefits. So usually, they normally, if you have a warrant out for your arrest, they really don't call and tell you. Just stuff like that. So just make sure people are aware. Don't give your information out to these people. Just hang up on them. And definitely report it to the Social Security Administration, their Office of Inspector General. The IRS scam, this happens all the time. Nestor, who used to work with me in the SMP, he said he got one of these calls the other day, claiming to be from the IRS and that he owed back taxes. And I told him, I said, well, Nestor, I guess they're coming to arrest you. But I mean, he just hung up on them. So that's, these scams are out there. It's another one of those that keeps on going. Social Security scam, IRS, it's like they're never ending. So just be aware of those. They're actually sending out emails and text messages also about the IRS, with this IRS scam. So please be vigilant of these. And also these actually needed to be reported to the IRS. And you can report these. I've got the link in this PowerPoint. It's phishing@irs.gov. So, and that's phishing with a PH. So that's where you need to report the IRS scams at. So, and again, I want to thank you all for everything that you all do as volunteers across the state. If you ever need any, questions or don't know if it's fraud, just give me a call, text, email, whatever. I'm available to y'all. Of course, unless I'm on vacation, but I'm there for you, and I want to thank you all for your, your dedication. I couldn't have gotten the numbers without you all, without y'all giving me the referrals or, giving people my name and number, anything like that. Y'all are my eyes and ears out there because I can't do this, by myself. So I definitely heavily rely on all of y'all to help me get the S&P word out there, especially about the scam. So, I always hear from people where, they've been to a presentation or whatever, and they've got my information and they wanted to report whatever. So, and it's because of you all out there that I've gotten those. So I just want to thank you all. So now I'm going to open up for questions. Does anyone have any questions? Okay, let's see here. I'm not seeing any typed in. Do y'all have any questions? Do you know of any new scams out there? Because please, if you do, please email me and let me know so that I can, get that scam out to everyone else. Amazon scam.
Loni?
Okay. Yes.
I've heard several places that you could get like $25,000 more for your Social Security. And this is advertised all over the place. And I just wonder what it's all about.
You can get $25,000 more for your Social Security?
Yeah.
I haven't heard that one.
I think what it is that you can get if you have TennCare and Medicare, you can get your Part B premium back in your Social Security.
Okay, so that kind of makes sense. Okay.
Yeah, I think that's what they're talking about.
Okay, that would make sense.
Thank you.
I may be
Okay, I'm getting several things here. Okay. Sheila said something about an Amazon scam. I'm not Sheila, can you tell us more about that Amazon scam? Sheila, can you unmute yourself? Okay, maybe we can go on to Sheila. Okay, we'll wait for you, Sheila. Okay, Ivy said that she received an email, I think, that she had a package delivery and needed to click on the link. And I think they've also been doing that in text messages also. I have heard that one.
That was a text message I received, and I just now received it while you were talking.
Oh, you're kidding. Oh, that's funny. So definitely, I mean, if you're not expecting any packages, I mean, most of the time they send those to you in an email. You know, if you're not expecting any packages, do not click on the link because you don't know where it's going. Just, you know, check it out first before you ever click on the link. Let's see, can people call about Advantage plans on the phone if you already have Medicare? It depends on what type of Medicare you have. If you are a current client of a Medicare Advantage plan, and that goes for TennCare plans also, so keep that in mind. So if they have, you know, any of the Advantage plans, it's their current plan that can call them. And I've even had beneficiaries say, well, you know, they'll have like a Medicare Blue Cross Blue Shield Advantage plan, and then they've got a United Healthcare TennCare. So guess what? They are current clients of both Blue Cross Blue Shield and United. So either one of those companies can actually call them because they are a current client. Now, if you've got, or if you've ever had also an Advantage plan, they can call actually old clients to let to see if they're wanting to come back or anything like that. They can ask them for quality questions, anything like that. How did we how was the customer service or whatever. So just keep in mind. So yes, there are Advantage plans that can call people as long as they are a current client. Unless there are some companies, Advantage plans, that have a, you have to sign a paper or whatever stating that you don't want phone calls or anything like that. So I would highly recommend doing that with the Advantage plan. You can call them and ask them for the form. Another one, my resident received a call from someone saying that they are assisting seniors in filling out applications and sending it to the White House, and they will get $2,000 from the White House. Oh, wow. Okay, I haven't heard that one. That's a new one. I'm not sure what applications they're filling out. This definitely sounds like a scam, because I mean, seniors don't normally get money for filling out applications. So, I mean, this is definitely some type of scam out there. It especially don't get money from the White House. So if, and it's a call that they're receiving. So I would just, warn beneficiaries, this a scam call. If they need help filling out any of the applications, the MSP, the LIS, or anything like that, they can come to you for those, free application, and no, it is not, they cannot get money for filling out one of those applications. They might be able to get their Part B, paid for if they fill out the, MSP application, or get their, prescription drug plan paid for and lower drug costs if they, fill out the LIS application, but they will not be getting money from the White House. So please, make beneficiaries aware of that. Anything where they're offering money, I'd just be wary of. Here Carol received a text that she had won $1,000. Woohoo! That probably goes along with those publishers clearinghouses and things like that. Just be wary of those. I know my husband keeps getting a phone call that we've won a vacation to wherever. I don't know. He keeps getting those. Oh, Sheila's on the phone and she can't unmute herself. Sheila, have you got yourself unmuted now? Okay, so let me go back to Carol's Worth's question. She was asking if anybody's on regular Medicare phone calls from Advantage plans. I said it depends on if they've got which Part D plan they have. If they're getting called from their Part D plan, like if they have, WellCare or whatever for their prescription drug plan or SilverScript, they can get calls from that company. But from Advantage plan reps, no, they're not supposed to be getting phone calls from Advantage plan reps. So you all need to get me the name of the phone, name of the caller. Especially, I need the beneficiary information, who called them, when they called, and things like that, so that I can actually get that person reported. And I need a full name. If they don't give me a name of the agent, it's very hard for me to report them.
Hey, Loni.
Yes.
If they're on like WellCare, can a WellCare Advantage plan agent call them?
Yes, because they're a current client. I keep going back to they are a current client. So it doesn't matter if they are current clients. of a plan, no matter if it's Part D plan, Advantage plan, if they're a current client, WellCare, that gives them permission to call them.
So, Loni, can you hear me now?
Yes, Sheila.
Yes. All
Okay.
right.
Okay, so this Amazon scam.
Okay, so we had gotten several calls where they would say they're from Amazon and they knew names, they knew addresses. We'd been ordering packages. They even knew amounts of how much,
Oh, wow.
we had spent. Yeah, I know, it was kind of scary.
That's kind of scary.
Yes, and they wanted us to send them money because something had happened to how it got paid. But of course it was a scam, and so, I'm like, y'all hang up, y'all hang up, y'all hang up. But on our TV station in Jackson, they, I think it was yesterday, they said a person got scammed for over $1,000 because they listened to what they said and they went out and bought some sort of card and sent it to them.
Oh yeah. Oh goodness. And that's another thing. If you get a scammer where you have to put money on a card or like a Green Dot card or any like Amazon gift card or anything like that, if they're asking you to put money on some type of card, it's a scam. Yeah, thank you, Sheila. I wasn't aware of that one. That one's an interesting one. And I guess, I don't know, Amazon probably has a place to report those scams too, I'm guessing. Definitely need to report that to the Federal Trade Commission. So if you get any of those, definitely report those to the Federal Trade Commission and probably Amazon.
Okay.
Okay, let's see here. Here's one. Scammers are sending out text about working as a surveyor, going to Walmart, et cetera, and being a mystery shopper. Oh yeah, those you have to definitely watch out for. They will send you a check, ask you to deposit into account, then purchase a gift card from Walmart, Target, et cetera, and send back to them. But you get to keep $350. Yeah, that is a full-fledged scam. If they are overpaying you and then asking you to send back the extra money in any type of form, either send it back by check or send it back by gift card or whatever, that should be a red flag for anybody. It's a scam. So if they overpay you, yeah, it's a scam. So please make beneficiaries aware. You got to be careful. Other places to check out businesses is the Better Business Bureau. Check to see if they've had any, any complaints with theirs. Check the FTC. There is the AARP, that scam watcher thing that you can check out for all the scams in your area that's been reported in your area. That's those. Here Kimberly said, so my mother was almost a victim of the grandparent scam and asked for money for a grandchild in jail based, of course, in New Jersey. There's those grandparent scams all the time. Those actually need to be reported to the Federal Trade Commission. So there's all sorts of different types of scams. Tina said she had a resident almost fall for the White House scam. So yeah. I'm hoping, especially, we need to get these words out to beneficiaries. And the caller I had yesterday, where I had one where she did give out her Medicare number to one of these scammers, and she was like, I keep seeing all this stuff online and stuff like that, and I keep saying, well, how are these old people, giving out their number? Why do they keep doing that? And she was like, and here I am, I did it myself. So I'm like, you're not the only one. There's, people out there that get, you get busy and stuff like that, and, call claiming, to be from Medicare. Hey, they need my Medicare number. Here it is. I just tell beneficiaries, please be vigilant. These unsolicited phone calls, don't answer them. Don't click on any links you don't know where the emails from. Delete all those. Set up spam. If it's you can also set up on your phone to block numbers, unknown numbers, and things like that. The hard thing about with the scammers, they're spoofing the numbers and they change them all the time. So even if you do block one, they'll just use a different number, and they keep doing that. So even I tell beneficiaries, normally the scammers will not leave a message, and eventually they will stop calling if you don't answer the phone number. If you answer the phone, they know it's a real number. They know there's another person on the end of that line because you answered. So if you don't answer the numbers, they don't know if it's a real number or not. So please, don't answer these unsolicited phone calls. Don't give out your information. I know I sound like a broken record. Don't give out your information and unsolicited phone calls. Watch, the emails that you click, watch the links that you click. If anybody's, requesting money for, to buy a gift card, to send them, to pay for anything, it's all a scam. Just tell them, we offer this information, filling out the applications, things like that for free. We're not, we don't, hand out money. We don't pay to get these done. We're volunteers. We're, trained by CMS and ACL. So, please be vigilant, and stay aware, because identity theft is like skyrocketed here recently. I mean, not even recently, it's just going, out of this world on, how these scammers are, and they change tactics all the time. So you just have to be aware. Anybody else have any questions or anything like that?
Loni, I do.
Okay.
Okay, my husband keeps getting calls from his insurance company, and the nurse wants to come over and check him.
Mm-hmm.
And he keeps telling them, don't bother him. He doesn't need to be checked. And they keep calling him.
I would call the customer service and just request that them, because I said there's probably a paper or something that you all have to fill out. Just tell them not to call you anymore unless it's, dealing with payment or something like that. I would definitely, go fill that question out. But what they're trying to do, it's called, I forgot what it's called, community something. But they're trying to, the Advantage plans do have some of these programs where they're trying to keep people healthy, if that makes sense. So they do have some of those programs where, that they can come, check people, especially for homebound people. The community needs assessment, yes. Thank you, Asha. But yeah, some of the Advantage plans do have that programs. It's trying to keep beneficiaries healthy, especially if they're, lower income or have multiple diagnoses, things like that. Or if, really good, they'll come out to the house. If you're rural and, it's hard for you to get to the doctor. So that's why they're actually doing that for a reason. They're trying to, keep people healthy, because if they keep people healthy, then they don't have as much cost, if that makes sense.
Well, I doubt that a nurse could do anything to make my husband more healthy.
Well, I mean, it's to check to make sure he's, taking his meds and, that's mainly what it is. But if your husband goes to the doctor regularly and things like that, I mean, it's really a personal preference. It's something you need to talk to your Advantage plan about.
Thank you.
Any other questions? Yeah, that is true. It's also helping to improve their star rating. Yes. As I said, you know, keeping costs down helps their star ratings. Improving access, it's also improving access. It helps with their star ratings. There's a lot of things that helps with their star ratings that a lot of the Advantage plans are doing. Yeah, it says they pay you for coming out, they check your meds and see if you have any questions. Something you didn't ask your doctor. Yeah, I mean, that sometimes they check your vitals and things like that. Yes, I mean, they do. They check to make sure you're taking your meds. If you have any questions. I said, you know, beneficiaries don't have to do it. It's just a personal preference. If you want, I mean, some people feel more comfortable doing that. Some don't. It's a personal preference. Any other questions? Yes, yeah. Linda says that they're trying to be proactive with your health care instead of reactive. Yes, that's another good reason. They are trying to be proactive. I said it goes all back to, you know, saving money, trying to keep you as healthy as possible. Yeah, that's another thing, just to call your plan to make sure that they are from the plan. And your plan should know, if you call customer service, they should know if they, you know, send a nurse out or whatever. But as I said, you can also say no. Beneficiaries can say no. They don't have to do this. And if they do get a call where, you know, say, hey, no, they cannot require it. They cannot require it to stay on their insurance. And that's what I was going to say. If you get an insurance company that is requiring it, let me know so that I can report them, because it is not required. Thank you, Dana. You and I must be on the same wavelength. It's kind of scary. Yeah, definitely. I highly encourage people to sign up for the do not call list. Now, and I get calls about this all the time. Even if you're on the do not call list, even the national and the state one, scammers do not go by that list. Hence, you know, they're criminals. Criminals do not follow that do not call list. So if you are, you know, getting those type phone calls and you are on both lists, it's most likely a scammer. So yes, I know Bonnie's put up some different phone numbers. Oh goodness, things like that. I don't know if anybody can post those. Did she send them out to everybody? Yeah, she sent them out to everybody. So Bonnie posted several different good phone numbers if you need that. She should have sent it to everyone. All right, so we are at 11 o'clock. And
Loni, I'll go ahead and take the presenting power from you. Sorry.
That's okay.
Giveth and taketh away. I did want to go ahead along with Lori, Olayinka, and myself. Just mention AEP really quickly here. I know that this year is sort of unprecedented in terms of everything. I think we could all use some precedented times at this point, but just a reminder that as of now, we are not having any face-to-face events through the remainder of the year, with the exception of those drive-through events that the coordinators and I have discussed, and I'm sure that all of the coordinators have discussed with each of you, you know, where somebody can pull up with their information and hand that sheet out through the window of their car for somebody to take inside to someone who can run that comparison. That comparison can be taken out to that vehicle, and then, you know, you know, away from the car, people can discuss what is in that. The reason why that one's different than anything else is by the law, your vehicle is a extension of your domicile or your home. So therefore, that person is inside of their vehicle. They're not outside. They have window. They should have protection on, even though they're still within their vehicle, if they're going to be trying to speak to somebody in some way. Of course, if you stand back far enough and if somebody can speak loud enough to hear, you know, people may decide that they don't want to do that. And I'm not, you know, saying that we have to enforce that onto our beneficiaries, that they're making sure they're wearing masks and everything. But if we are providing that to them, we must. You know, it's handed down from us that we have to have, you know, we have to remain socially distant and protect our seniors, since we serve the population who is really the most impacted by the state that we're in right now. So aside from that one specific thing, we will have no face-to-face counseling, contact, outreach, whatever it may be. Everything must be conducted through mail, email, fax, something like that. Obviously, if you are a volunteer who works for another company, and through the course of doing your work through your company has decided that they are not going to adhere to that socially distanced thing, there's nothing that we can do to block you from that. So, you know, I cannot enforce that on anybody to do that. But for our volunteers who are not working for some sort of entity or organization, we will not be allowing any socially or any face-to-face stuff if you're representing SHIP. If you want to do that on your off time when you're not representing SHIP, that is perfectly fine, but you will not be allowed to be a SHIP representative and go and do face-to-face counseling or anything like that. You know, it is unfortunate. I would very much like to just leave that up to everyone's own discretion, but we have been instructed, you know, since March that there is to be no face-to-face contact. That's why we canceled all of our trainings and all of our outreach throughout the course of the year. As of about the second week of March was when we had everything be shut down there. If anybody does find out that anybody is going against that, I ask that you please report that to me so we can go and discuss that with whomever is choosing to go against that. Coordinators, we've already had our call regarding all of that and what the stance that TCAD has with that. But I did just want to make sure and remind everybody that is the stance, unfortunately, is that we will not be having any face-to-face counseling or outreach throughout the remainder of the year. Just as soon as I'm given the go-ahead that we are all clear to start with our normal procedure with SHIP, I'm more than happy to give that power back to all of us. You know, I've not spent one day outside of the office for the last 4 months. So I'm absolutely ready for all of that to go back to what we would call normal, but in the interest of protecting our seniors, and I do hope that everybody else is protecting themselves. Whatever you dictate your own form of protection to be, that's none of my business to make that call, but I am happy to be able to report that nobody within the program has reported, you know, that any beneficiaries that they've interacted with has come down with COVID, and we've only had a few reports of COVID associated with our program. So, I'm happy to keep that number low and would like to continue and ask that everybody please respect that and follow that rule if we can. Lori and Olayinka, if y'all would like to add anything, please do, and then y'all can let everybody take a short break before I believe Chris is up next to speak.
Hi everyone, Olayinka here. We're coming up, we have I think about like 4 minutes before Chris is gonna get started. I'm gonna make sure he's good to go, and we'll probably just go ahead and start with his presentation, so that way we can go ahead and get started with lunch a little bit earlier. So give me just a few minutes, okay?
Can you guys see me or hear me?
Chris, I can see and hear you.
Yes.
Yes.
Perfect. Can I do a quick test of the share screen, make sure the PowerPoint can come up?
Yeah, absolutely. Go for it.
Doing it now. Everything went real smooth yesterday, so I'm expecting the same, but let's just be sure. And from the beginning.
I can see your presentation.
And no presenter notes, correct?
No presenter notes.
We're all set. I'm going to unshare for a second.
Go for it.
And there it is. This is perfect. You guys have been incredible in helping me get up to speed on WebEx. It's a different platform than what we're used to using, but this has worked great.
Hey, can y'all hear me?
Yes. Can now, Olayinka.
Yes.
Okay, sorry. I just went ahead and gave Chris an introduction, and I was muted the whole time, so I'll start over.
I'm sure it was a good one.
Yeah. For our documents and trust portion, we have Chris Johnson. Chris is an attorney with Takacs McGinnis Elder Care Law with 19 years of both legal and military experience. He served as second lieutenant in the United States Marine Corps and currently provides legal expertise with a focus on estate planning, VA benefits, and probate. He is a member of the Tennessee Bar Association and enjoys swimming, sailing, hunting, and coaching Little League Baseball. Whenever you're ready, Chris, go ahead and take it away.
Thank you guys so much for the introduction. I'm very glad to be here. I love doing this and educating people out there with regards to the kind of the 30,000 foot view, I like to call it, regarding elder law and elder care. And what I want to do is I'm going to walk you through kind of all the critical aspects of what was considered effective planning for a senior citizen. And frankly, some of this planning is for anyone who's an adult, anyone who's at age of majority. If you start to have a family, powers of attorneys, at a minimum wills. I'm going to talk about the difference between wills and trusts. And I like to say, some people say, well, you should have a trust. Other people, no, you should do a will. And what I like to say is all these things are tools in the toolbox. And for those of you that are handy out there in the audience, you know what you try and do with any project is bring the right tool for the correct fix. That's what we're looking to do. And so whenever someone says, oh, you definitely want to do this or definitely want to do that, in reality, what you want to do is make sure that your planning documents and what you have put together suits your personal needs. We're all different. We all have different family situations. We all have different health concerns. We all have different financial pictures. And most importantly, we all have different worries. And a lot of this boils down to what I like to refer to as risk management. I mean, this is risk management regarding your life. We often don't think of our lives as its own little mini business, but that's what your family is. It has income, it has expenses, it's got deadlines, appointments, it's got legal authorities, and all of those things need to be managed and need to be accounted for. So if something happens to you or something happens to a loved one, your plan can make sure that at least from a legal perspective, from a financial perspective, from a healthcare perspective, those issues, if they can't be solved immediately, can be managed until you get better or until the issue resolves itself, unless obviously it's a passing, at which point we want to make sure there's an orderly transition of your affairs to the next generation. So let me, without further ado, start sharing this PowerPoint, and I'm going to bring it up here. And can everyone see it cleanly? All right, I'll take, oh, there we go. I got my yes, very good. So as you know, I'm Chris Johnson. Just a quick little bit about me. I'm a retired United States Marine. I did 15 years in the Marine Corps. I started out as an infantry officer, and then the Marine Corps sent me to law school, amazingly enough. And I went to the College of William & Mary School of Law, loved every minute of it, served as a judge advocate. And then when I got out, I kind of referred to my civilian life as Act 2. And I wanted the same thing that I had when I was in the Marine Corps, and that's kind of a calling, that reason to wake up every morning and feel like I love what I do. I get to help, amongst other people, a lot of families in our community, which feels good, especially as a VA accredited attorney. I have a focus on veterans and veterans planning and veterans needs, and that means a great deal to me. It kind of keeps me connected to my former life. And it makes you feel like you're doing good every single day. And so that's a little bit about me. So let's jump right into it. Some common misperceptions. One of the first ones, one of my favorite ones, all I need is a will, right? And I get people, I mean, every single month, people will come in and they're very elderly and they're like, well, I just figured it was time that I get this stuff taken care of. And it's, if you're getting it done anytime before you pass, that's a good thing. But waiting till the last second is not a good plan. And so there's so much more that goes into it than just a will. A will covers what we're going to refer to as your probate assets. And that's what everyone kind of knows is, well, there's that process, I think it's called probate, where you go to court and you show them the will, and then everything kind of gets taken care of. And to some extent, there is some truth to that. Probate's a little invasive. It's all done under judicial scrutiny. It's costly. You oftentimes need to hire an attorney. It can be inconvenient. You have court costs. You have reports to the court that need to be issued. There's a creditor waiting period of 120 days, so that takes some time. And it's generally, most people consider it not a fun process. Not that it's always a bad process. There are certainly times where I think probate's a good thing. But for the most part, if we can avoid probate, we want to avoid probate. And so you think of that and say, okay, what are my documents and what are my most important documents? So the will takes care of things after you pass away. But sometimes we get sick, we become incapacitated, we have a stroke, we have an accident, something awful happens to us, and that will isn't in effect yet. And what you need at that point is you need powers of attorney. And powers of attorney are that legal handoff of the legal authorities that you have in your life, both financial and healthcare. So financial, You have the right to contract, the right to open and close bank accounts, the right to sign checks, the right to transfer real estate. You have all these authorities that when you turn 18 years old, you are imbued with, and those authorities need to be handled if you are still alive. So going forward, a will, what does it take care of? As I said before, it takes care of the probate assets. Those are assets that are owned in your name and they're not otherwise accounted for. So on your bank accounts, you can do something called a beneficiary designation. So if I have a checking account and I have $5,000 or $10,000 in it, I can execute a beneficiary designation form at my passing. My bank account goes to my wife, or my bank account goes to my brother, or my bank account goes to my mom and dad. And so you can designate that to whomever you want. The second you do that, it becomes a non-probate asset. With stocks, you have transfer on debt, TOD, and so they can be transferred. Retirement accounts, IRAs, so the 401k, same things. And then assets that are held in a trust. Because a trust is a legal entity, if you have something that is either titled in the trust or payable on death to the trust as a beneficiary designation, that trust supplants the probate process. And the reason being is the probate process is when you pass away and your account is not beneficiary designated, there is no legal lawful owner of that account anymore. And probate is the orderly transfer of assets from one generation to the next, and your will says where it goes. But you don't need probate if you have taken other steps to have it pass in another manner. And that's what the trust functions as most often when you're using a revocable living trust, is to make sure that your heirs, your family, does not have to go through the probate process. And it is a great tool for avoiding those inconveniences that I spoke of earlier. Some other misconceptions, one of my favorites, there will be a formal reading of my will. We still see this in TV shows and movies. I'm trying to remember the last movie I saw it in. It was I think a James Garner movie, one of his last ones. And they sit down with the attorney and everyone's very solemn, and the attorney breaks out the will and kind of reads the big stipulations. Well, that is a very archaic thing that harkens back to a time where the reason there was a reading of the will was essentially twofold. One, the attorneys, when wills were executed, oftentimes held on to the original document because everyone else lived in wooden homes, real risk of fire and losing everything. And the attorney had a safe, and usually the attorney and the bank in town were the only people who had a safe, so the only place to keep the documents safe, and that's just not the case anymore. Number two, way back when, oftentimes literacy isn't what it is now, or wasn't what it is now. And so the very few people were actually literate enough to read the will. And so the attorney read the will because he or she was one of the people that was literate enough to read the will and inform everybody what's in it. It is not required. Every once in a while, people will get upset. I thought there was going to be a reading of the will. It's just kind of an archaic formality that isn't necessary or required. Now, this is another big misconception, that somehow a spouse, but I'm his wife, but I'm her husband, that because I am married to this individual, I have legal authority. They're in the hospital and a healthcare decision needs to be made, and there's no healthcare power of attorney. Bills need to be paid, but it's not a joint account, and the spouse is saying, well, but I'm their spouse, I can sign on this account. Unless you do these things, dot your I's and cross your T's and make sure all of these powers are put in place, you will find yourself in a position lacking authority that you need to take care of a loved one or to manage a loved one's affairs. And you cannot rely on the fact that just because we're married that this is a solution to everything that's out there. It most certainly is not. So now let's talk about that durable general power of attorney. I was getting into it earlier with regards to what are your most important documents. The reason I call the powers of attorney your most important documents is because from the principal's perspective, and that's the person executing the authority, the person for whose benefit, because they're setting up the power of attorney so someone can help them. Why is it their most important document? It's because it helps during their lifetime. Once you pass away, your power of attorney is extinguished, both healthcare and durable general. It has no more effect. And people don't realize that using a durable general power of attorney after you know that the principal has passed away, that is a huge no-no and a problem that most people don't quite realize. And the reason being is, think of a power of attorney like you're on Microsoft Word or email and you're highlighting a portion of text. Well, when we turn 18 years old, we're all imbued with certain legal rights, and I hit some of them: opening bank accounts, writing checks, signing contracts, selling property, all these things that we can do just a matter of course from being alive and being an 18-year-old American. Well, you take those rights that you have and you essentially are highlighting them, and then you're clicking on the copy and clicking on the paste function. And what you're doing is you are pasting them onto another person. That other person is called the attorney in fact. So if I'm executing the power of attorney, I'm the principal. And if I'm giving that authority to my wife, which I have done, I execute the power of attorney and make my wife my attorney in fact. Now she can conduct business transactions, sign contracts, sign real estate, do all those things that I could do personally. Must a principal be competent to sign a POA? Yes. You can't just put it under someone's nose who doesn't understand what they're signing and has no idea what day of the week it is, who the president is, anything like that, and just think, well, I'll just have them make them up. They must understand the document that they're signing. Who can be an attorney in fact? So it's got to be someone who's an adult, someone who's able to legally do these authorities. So I have a 12-year-old son. I cannot make him my attorney in fact for a lot of different reasons, but the big one is it wouldn't pass muster with the law. And so that's what you're trying to do. Now, my favorite thing is 3 big things that you cannot do with a durable general power of attorney. Number 1, it's 2020. We got a big election for those of you that haven't been watching the news, and probably a lot of us are avoiding the news these days. You cannot vote on someone else's behalf using power of attorney. That is an authority, a legal right that is too closely vested with the individual. So you cannot have your power of attorney vote for you. That is something you must do yourself. The second thing is you cannot have your power of attorney execute a will for you. The opportunity for mischief is just too great. I'm someone's power of attorney, they're on their deathbed. I quickly execute a new power of attorney, leaving everything to me. The opportunity and that draw for someone to do something wrong is way too great. And the law has just said, nope, we're not going to allow that. And the third thing, probably my favorite thing, is you cannot stand at the altar in someone else's shoes and marry them off. So if I were power of attorney for someone else, I couldn't stand up at the altar and say I do in their place and marry them off to something else. So a little humor in there. What makes it durable? So we talked about being competent. At some point, you may become incompetent. And when you become incompetent, you lose your ability to act. Well, one of the many acts that you can do while you're competent is revoke your power of attorney. You can revoke it at any time. In the great state of Tennessee, you can do it verbally or in writing. And what happens is when you lose that authority, the law has said, unless you make it a durable general power of attorney, the authority of that power of attorney extinguishes. All we want under the law is to make sure that you have contemplated that if I become incompetent, I still want this to be in place. Because frankly, for the most part, that's when it's going to be needed the most. Is not when you're competent, because most of the times you can do all those transactions or take care of all the business you need to take care of while you have competency. It's when you become incompetent that it truly becomes most important. And so if that's why you're doing this planning, make sure you're executing a durable general power of attorney. What does the attorney in fact do? I kind of went over the do's and don'ts. Is there a code of conduct? Yes, you have a fiduciary obligation to do what is in the principal's best interest. And so if you are the attorney in fact for an individual and you start gifting to a sister because you have authority over their bank accounts and that person has never made those gifts before, never indicated they want to make those gifts, you are violating your fiduciary obligation. And so yes, there is most definitely rules of the road to being an attorney in fact. You have an obligation to do what's in their best interest, to not self-deal, to make sure that their wishes are honored. And if they still have competency and tell you not to do something and you do something anyways, that is exceedingly problematic and a gross breach of your duties and obligations. Having power of attorney does not make you the boss of the principal. In fact, whenever I do it with parents and children, I emphasize that point at the meetings. Mom, Dad, you guys are still in charge. You are still competent. You still have the authority to tell the kids, you know, this is what I want, this is what I don't want. And some people are surprised to hear that. It's very important that they recognize that and that they understand that just because you give power of attorney, you have not vested authority over you in someone else. What you have vested is the ability for them to conduct business in your name in accordance with your likes, wants, wishes, etc. So advanced directives, healthcare power of attorney, living wills, the post, the Tennessee physician orders of scope of treatment. So what are these? So the healthcare power of attorney, that is the one document that designates an individual to make your healthcare decisions when you cannot do so. And that is exactly what that document does. It says mine gives that authority to my wife. If I can't communicate with the doctors, if I'm in a comatose state, my wife can answer their questions and give them a direction because she has legal authority under the law via that power of attorney. Now, what I differentiate that between that and the living will, and sometimes you will see these documents combined, but a living will is like the roadmap. A living will is the document that says no life-sustaining treatment, no extraordinary measures, no feeding tube, no artificial breathing, no blood transfusion, whatever things, those specific things you want. And it can be very broad or it can be very detailed. It really comes down to what you want. And so I use an analogy to explain this with people. And the analogy is your life is like you're driving a car and you get in the car is your life and you're the driver. You know where you're going, you're making all the decisions. At some point, if you become incapacitated, you can't drive your car anymore. Well, that healthcare power of attorney now gets in the driver's seat and you're in the passenger seat because you cannot function the car anymore. Now, there are two ways that person can know what to do. A, you've had a conversation with them beforehand, which is what I would highly recommend, is you sit down and say, these are my wishes, these are my desires, should these things happen to me. If you feel as though I'm not convinced that they will do what I want them to do, which is never a good thing to put that person in charge in the first place, or you feel like they need added direction, the living will is kind of like the GPS. Kind of says, listen, turn left here, turn right here, no life, no extraordinary measures, no breathing, artificial breathing, no feeding tube, whatnot. One of the things I emphasize is oftentimes medical professionals who do absolutely wonderful work will see a living will and feel as though they don't need to consult with the power of attorney because we have the roadmap. And that is always the tension that you have. And so I will often recommend, unless you really feel you need it, just execute a power of attorney. Don't do the living will. Now, there's a time, like I said, everything's a tool, and there is a time where I'll recommend a living will. But for the most part, you can never predict accurately what your medical condition is going to be, what the circumstances are, what your prognosis is. And so what you really want is an individual to look that doctor in the eyes, ask some questions, demand second opinions, demand additional testing, have all the facts and circumstances before they make that decision. Vice having a living will where your life can be decided by, it says no extraordinary measures, we're not going to do any extraordinary measures. Well, it really depends on what the issue is that you are facing at the time. And sometimes a second opinion is very much warranted. Everyone in the medical field knows it is sometimes very uncertain. They run tests and they try treatments and they see if it works. Maybe it works, maybe it doesn't, maybe we shift treatments, and it's a very fluid environment. And you need someone, at least from our philosophies, you need someone in there advocating for you throughout the process. And then the post, that's a document that you're, especially if you're going in for surgery, if you're being admitted to the hospital, if you don't have any of this, they'll ask you to fill out so that they have something on file, on record, so that they can rely on making decisions without the absence of any authority. And so I would kind of refer to that as the bare minimum. If you're ever going in for surgery, if you're ever being admitted to the hospital, have that healthcare power of attorney, have their contact information, let them know that you're going to the hospital. provide that stuff to the medical team, to the hospital staff, so it's in your file and they know who to contact and how to contact should it become necessary. Let me keep an eye on time here. All right, I'm 15, 20 minutes in. I've got a lot of slides, so I'm going to try and keep my tempo here. There's a lot of things going on. Why do we have an advance directive? You can read the quote, not because you have an illness, but because you have a family. It is a gift. One of the most difficult conversations I ever had to have was with a client who told me, as they were trying to work out their own power of attorney authority, that they had a power of attorney authority for their parents. And unfortunately, they came to the circumstance with both parents where they had to withhold treatment in accordance with their parents' wishes. And they had two other siblings who were younger, and their family didn't really talk about these things too much. They kind of kept everything private, but they had shared with their eldest son what they wanted. And he looked me in the eyes, and I was wondering why he was having so much difficulty and who to assign with this. And he began to tell me the story, and he said, Chris, I know two things for certain in this world. I honored my mom and dad, and I followed their wishes with what they wanted by ensuring that the medical extraordinary measures were withheld. They were ready to go. And he goes, the only other thing I know in this world is my siblings have never forgiven me. And that is a really difficult thing to hear. And so when you put this in place, make sure your family members know what's going on. Make sure your family members understand what your wishes and what your desires. And if you want to put someone in charge and they can't honor your wishes, because some people hold very closely held beliefs on these and strongly held beliefs, and that's okay. We're all allowed to have our own personal opinions and feelings on these issues. But the people who you put in charge of your decision making need to be able to follow your wishes to a T. That's why they're there. And so I always like to say, failure to plan is planning to fail. If you don't put these documents in place, you are asking for trouble down the road. And so that brings us to conservatorships. And a conservatorship is what you need if you don't have power of attorney authority. And so we talked about that copy and paste idea of taking your legal rights, copying them and pasting them on another. Well, when you copy and paste them, those legal rights are with both people, which is nice. It gives you some flexibility, So there are some bad events that we get better from and we come out of it and, we don't need the power of attorney anymore. With a conservatorship, you are asking the court to cut and paste your rights, to take your rights away, cut them, and paste them on another individual. And so at that point, what you are referred to, the person who needs the conservatorship is referred to as the ward. Someone else, obviously, who has capacity, competency, petitions for conservatorship to be put on the ward. It's expensive, but now we're talking tens of thousands of dollars. They can be very ugly. I've been a part of one that was a contested one between a brother and sister. It was exceedingly unpleasant because think about it. It's a custody fight, but it's a custody fight with the bank accounts on the line. It's like custody over the children, except the children sometimes have hundreds of thousands of dollars, sometimes millions of dollars in assets, and the parents in this case, and whoever gets conservatorship gets control over those assets most often, not always. Sometimes they'll split, make someone conservator over the person, another person conservator over the finances, but that's unusual. But that's not how you want this to play out. What you are doing is you are sowing the seeds for discord and discontent between family members, between children and a parent, especially if you have a blended family where you have biological children, and then you have a second marriage, a spouse who isn't blood related to the children, and they may see things differently on how to care for that ill spouse or what decisions should be made. If you have a plan and put those key players in place, the odds of what you want and your wishes being honored are much, much higher than if you go via conservatorship, turn it into a fight and turn it into a costly fight. And by the way, those costs are borne by the incompetent person. It will come out of their finances. And so it's just from a financial planning perspective, a very bad way of doing it. So have the conversations. Don't rely on people to do the right thing, because doing the right thing is a nebulous term. What's right to some people might not be right to others. The right thing is what you want to have done for you. And so the other part of it is a burden to force, even if everyone's getting along and everyone agrees what to do, it's still a burden to go to the court, to have an attorney assigned, as an attorney ad litem assigned to the ward who does reports to the court. And then every time you want to make a decision in a family that works well together and everyone's happy, and they have to basically go mother may I to the court every time they want to make a significant financial decision where they shouldn't have to do that. Everything's functioning properly. If they had a durable general power of attorney, they wouldn't be worried about that. And so it can be very invasive on your lives as well. Okay, we're going to shift gears a little bit. We're going to talk about long-term care. How does it get paid? I'm going to go over the elder care continuum and kind of show you the science behind the aging process and start to see how all this goes together a little bit. Everyone thinks, well, I mean, it's amazing how many people just don't know the difference between Medicare and Medicaid. And especially in this audience, I'm sure you guys are out there and seeing people who are misinformed on all sorts of things. And I was listening to the previous session and the scam calls and all these lies that are put out there. It is very, very, very frustrating. That misinformation creates uncertainty. That uncertainty creates fear. And then people aren't sure what to do. They make bad decisions. They trust the wrong people. And so we need to make sure that they are in a good financial position and they are accessing the resources that are available for them. And they are doing so in a manner that protects them, because at the end of the day, with what we are trying to do with life care planning is you are trying to make sure that someone's healthcare needs are being met, that they are safe in their environment, and that their legal, financial, and personal care needs are taken care of over time. And so here is the elder care continuum. And the first line in that is functionality. And so what I always say is at 18 years old, you are on the left end of that. Barring some unfortunate circumstances, and in person. Now you still might rely on mom and dad for a little bit, but under the law, you are 100% independent. And what's interesting is, for most of us, we stay at the very left end of the curve. It's not a linear straight across, hey, I'm just going to travel across this a little bit at a time. No, for 30, 40, 50 years, we're fully independent. And then what happens is it kind of surprises us as we start getting older that we have limitations, that we become more and more dependent. I like to joke that I have moved just a little bit across that curve. And I did 2 years ago when I got these. I put off getting glasses for a long, long time. I didn't want to get them. But I was in a restaurant, and it was dark, and it was a small print menu, and I simply could not read it one day, and that was kind of it. And I couldn't believe it, and I shook my head. But I have moved a little bit without my glasses, under certain circumstances and certain environments. I cannot function, and so I have moved down it just a little bit. If you have someone mow your lawn because you're just not up for it, you've moved down a little bit. Someone does the gutters or the high dusting in the home because you don't want to get on a step ladder or on a step stool. You've moved down just a little bit. Now, is it a big deal that you've moved down those? No. But why I emphasize those is I think we're all here familiar with the activities of daily living, bathing, toileting, and dressing, and preparing your own meals and feeding yourself, and safely ambulating in your environment. Those are the big things. Those are the big activities of daily living, and those move you significantly down the curve. But I always say, if you can catch the small things, you will see the big things. And you'd be surprised. You think, well, Chris, who possibly is out there wouldn't realize they can't dress themselves? And the fact is, a lot of people. I was going over, ADLs with a client and with clients' kids. I said, hey, can mom and dad dress themselves? And they were like, oh, yeah, they can get dressed, put their shirts on, put their pants on. They can't put their shoes and socks on anymore. They need help to do that. They physically cannot do it. And I said, well, they're not dressed then. And they looked at me and said, well, no, they're dressed. They can, And I said, well, no, they're not. Where can they go? And they looked at me with a puzzled look. And I said, okay, I'll give you they can go to the beach. Where else is it acceptable for them to be without shoes and socks on? So they can't go to their grandkids' school, they can't go to a restaurant, they can't go to a store, they can't go to church, they can't go to the city hall or vote. They can't go anywhere because you can't go to those places without shoes and socks. And if you don't have shoes and socks on, you're not dressed. And they were a little taken aback by that, but they got it. And you could see kind of the light bulb go off. And the reason being is we're Americans and we think, hey, we're very can do, independent. If I can do something most of the way, I can do it. Well, the problem is activities of daily living aren't things that you can do 70% of the way. You can't almost feed yourself. You can either feed yourself or you can't feed yourself. You can't almost dress yourself. You know, you either dress yourself or you can't dress yourself. And the other one I always like to share is the one, you know, can they still cook and prepare their own meals? And they said, well, yeah. They, you know, mom loves to cook. We've only called the fire department 3 times this month. And I laughed and I felt so bad because they just stared at me deadpan. It wasn't funny. They were telling the truth. And that was a banner month for them. They had called it more often. And we kind of had to unpack how accidentally setting the home on fire is not a reasonable result of cooking and preparing their own meals. And as we unpack that, they began to see what was happening. And that was a great example of caregiver burnout. They had been caring for mom for over 3 years, and they also cared for teenage kids. They had 0 free time in their lives, and so they did not realize what a big problem that was. And so now when you have that functionality, now what we're trying to do is we're trying to marry up that functionality with the care that you need. Make sure that you're receiving the care that you need. Now that second line, which starts out at home sweet home, all of these you can see are places, and that's because the care you're receiving is so often aligned with where you're residing. And so when we don't have any functional limitations, we're living at home, and we all want to live at home. Home sweet home is where we all want to be. But at some point we start moving down. Well, then you can live at home with an assistance and have an in-home caregiver. Then you can start moving into maybe an independent living facility, an assisted living facility, memory care facility, and then obviously the nursing home. And every one of those things has a requisite cost. And so when you go down to line 3, you see the cost of care. And now living at home, it says none. And I want to explain that. It's not that there isn't any cost to that. But that's your budget. That's what you factored in and have been living on your whole time. We're looking at additional care costs. And so you bring an in-home caregiver and you're looking at about $20 per hour. And I'm going to make a note here of why that $20 an hour is a misnomer right there, because then we move into retirement communities, independent living facilities, $2,000 to $3,000 a month, assisted living, maybe $4,000 to $5,000 a month, memory care, $5,000 to $6,000 a month. And then nursing homes, you know, $6,000, $7,000, upwards of $10,000 a month. It's $100,000 a year, and those are catastrophic costs for individuals. And so what we do is we look at what resources are available, and that's the last line. And so we have private funding when you're living at home yourself. Then you also have family members. Then if you're a veteran, there are certain VA benefits, which I'm going to address later, which might apply. There are community services, and then obviously as you go through, there's Medicare, Medicaid, and Medicaid TCAD. That is the big one that everyone's looking at. And what we are trying to do is make sure that your care costs are being buttressed by the resources that are available in a manner so that the individual does not run out of money. Now, that's one of the first things. I have to sell everything to pay for my care. That's not the case. It's not true. People, you know, generally know 2 things about TCAD. They're going to take my house when I pass away, and I have to have under $2,000. And those are tiny little snippets of a very Byzantine and complex government benefits program. And there are rules that don't seem very favorable to the claimants, but there are rules that are very favorable to the claimants. And the goal is to understand those rules and apply those in the manner most beneficial for our clients, for the claimants, to put them in the best fiscal position possible. So the state will take my house. That's the biggest one everyone's worried about. That is called a state recovery. If you own your home, and you go on TCAD after you pass away, the state can ask for your home to be sold so that they can be paid back first. However, That is only for property that is in your name. And so one of the key planning tools is an irrevocable trust, a 5-year look back trust. Some people will look at them or call them as. And what you do is you place your home into an irrevocable trust. I like to say it's taking your estate plan and putting it on its head. Most of us are used to having all our stuff. We pass away, our will, our trust passes everything to the children, everything goes to the trust and then out to the kids. Well, what this is doing is you're giving it halfway away and you're placing it in that irrevocable trust during your lifetime. You still have a right to live in your home. You still have a right to make it your home for as long as you wish. But what's happened is after you pass away, because that home is not in your name, it is not subject to estate recovery. And so people say, well, what's the catch? And that's where that 5-year look back comes in. TCAD has a 5-year look back penalty for any gift, any transfer of assets for less than fair market value, what you and I would call a gift. So if I give away $10,000 or $11,000, TCAD is going to penalize me. They have a penalty divisor. So let's say I had $12,000 and I know I have to be under $2,000. So I write a check to a friend of mine. I write it for $11,000. And now I go to TCAD and I say, hey, look, I have less than $2,000. What they're going to do is they are going to put me in a penalty period for 2 months. And so, yes, I have qualified, but I will not receive the TCAD benefits until I am through the 2 months of that penalty. Well, when you transfer the home to an irrevocable trust, because the trust isn't purchasing it from you, you have gifted it to the trust. But the catch, the caveat is they only penalize transfers for less than fair market value within the last 5 years. So you transfer it to the trust, and then 5 years later, there's no penalty. And people say, well, do people really plan that far ahead? Yes, the ones that are financially savvy and the ones who really want to protect assets for the next generation, because for most of us, our home is our biggest piece of wealth that we own. It is usually the largest asset in our portfolio. And if you are able to pass that home down to your children in a manner where it's not subject to estate recovery, you have preserved that asset for generations. And that is a great, great planning tool to use. And so you always want to look at how do we do this so we can avoid the estate recovery. Some people say, well, Chris, why should I put it in a trust? Why don't I just gift it to my children? Well, there are 2 reasons. Number one, when you gift an asset, you are not mitigating the risk. You are shifting the risk. And remember at the beginning, I talked a lot of this is risk management. What we're trying to do is mitigate the risk to our clients, mitigate the risk to anyone who is trying to go on TCAD, so they are not financially penalized or financially penalized as little as possible. If I own the home and I'm worried about estate recovery, that risk is there with estate recovery. If I deed it to my children, now I'm worried about a divorce, I'm worried about a bankruptcy, I'm worried about a personal injury lawsuit because it's theirs. I've met with people who said, well, I just transferred everything to my children. And I said, well, that's great. If something bad happens to your children, you lost your nest egg. And I actually had someone tell me, well, no, I didn't. It's not theirs, it's mine. You know, I just deeded it to them. And I said, when you deeded it to them, you made it theirs under the law, and it's subject to all those risk factors. And people don't realize that. Also, when you gift it, you lose the opportunity for a step up in basis. So if it's a property you've held for a long time, if they inherit it or if it transfers through a properly drafted irrevocable trust, they are going to get the new basis at your passing. Whereas if you gift it to them, they are not. They're going to basically take on the old basis, and when they go to sell it, they are going to have a much larger tax hit. And those tax consequences can be devastating for families that have owned property 30, 40, 50 years, of which there are a lot of people out there. And if we can avoid that, we most certainly want to avoid that. Let me check how I'm doing on time. All right, I got about 20 minutes. I'm going to try and go faster than that because I'd like to open it up for questions at the end. Joint accounts, that's another one. I'll just put my children on the account. No, now one, you haven't, it doesn't divide your interest in the account. So if it's a $100,000 account and you put your child on it, it doesn't mean, well, now I'm only responsible for $50,000 of it. And worse off, again, if your child gets a divorce, if your child has any other big issues, now that is a resource of theirs, and so someone can sue to get that, and you have to be very concerned about allowing your assets to be subject to that type of risk. So joint accounts, not a great idea. All right, so now I promised we'd get into VA benefits. Now these are pretty busy slides. I'm gonna try and move through this pretty quickly and hit the key wave tops. VA, established in 1930. Amazingly enough, only a cabinet level position when 1989 rolled along. It is a huge, second largest governmental department after the DOD. You can look, I mean, it employs a good sized town. That is broken into three sections: the Veterans Health Administration, Veterans Benefits Administration, and the National Cemetery Administration. And I point that out because people say, well, just go get your VA benefits. Well, your VA benefits very much are dependent upon where they reside within the VA. You have your health benefits, you have your financial benefits and your burial benefits. You need to know who to talk to in there, because when you're talking to the wrong entity, you are not going to make any progress, and you are going to become very frustrated very quickly. And as you can see, look at their liabilities. Long-term liabilities for VBA, 2.5 trillion. Look at that VHA, the largest healthcare provider in the country, over 1,200 medical treatment facilities. It is a Byzantine network, and knowing how to navigate it matters a great deal. So VHA, everything flows through a 1010 easy. This is for your health benefits. They have 8 priority groups. And what you do is you submit that, they put you in a priority group, and you get to see this is where I'm gonna, they have a limited number of services, and depending which priority group you are in, it'll determine which benefits, which health benefits you get. Am I gonna get prescription benefits? Am I gonna be able to be seen at a facility? And so everything starts with that 1010 easy. If something doesn't go right, then what you want to do is every primary care physician has a social worker. Reach out to that social worker, ask to talk to the assigned social worker, and if you don't have any luck with that, then go to the patient advocate office. You are always owed an explanation if things aren't going in the manner you thought, why that is happening, and most importantly, what can be done to rectify it. Then we have the Veterans Benefits Administration. And so we have basically 2 big tools in there that we deal with on a daily basis. And that is your service-connected pension and your service-connected compensation, and then your non-service-connected pension. So service-connected compensation, what is that? I have an injury that I received in service. It still hurts me now. And so the VA compensates it. And what they have is they just have this huge set of tables for every malady that you could have under the sun. And so like I'll give you an example. I have one. That's my pinky. If you can see it on the video, I'm not sure if it's showing now that I'm sharing the screen, but I can't straighten my pinky. There's actually a code for that because my pinky got broken in service and it got repaired and it never got repaired correctly. You see those 10% because the earplugs were faulty. There are all these things out there. There is no financial eligibility. If there is a nexus between your injury and your service, they will assign it a percentage, and the percentage, it could be a whole hour class on how they do these percentages. Just understand that if you have 10% for this and 10% for that, it does not equal 10% or 20%. They have this crazy math set up and how they do it. And so don't just add them together and think that's what I get. Talk to a VA accredited attorney and they'll explain to you how they got the percentage that they did. Now, for the non-service connected pension, we have all sorts of eligibility criteria. You had to have served 90 days on active duty. One of those days had to come during a wartime period. Your discharge had to be non-dishonorable, and that, there are 5 characterizations for enlisted personnel, which would be the vast majority who you deal with because they're the vast majority of the military. But there is an honorable, there's general under honorable conditions, there's other than honorable. Those are your 3 administrative discharges, and then you have your 2 punitive discharges, your bad conduct discharge or your dishonorable discharges, which can only be awarded at courts martial. Now, How the VA sees non-dishonorable and how the Department of Defense sees dishonorable are two very different things. And so just because you see a bad conduct discharge, some people say, well, if you don't have an honorable, you're out of luck. That is not the case. You need to look at the facts and circumstances behind the discharge. You can appeal a discharge at a discharge review board or the Board of Corrections for Naval Review. Every service has one. You can also ask the VA to give you a determination on the characterization of service. And that determination doesn't change your upgrade, but it might change how the VA recognizes it. And so maybe you have an other than honorable, but they consider that not a dishonorable characterization, and therefore you will still be eligible for VA benefits. For the medical, you're going to need to be either 65 and over, or be 100% disability. It doesn't have to be service-connected disability in this case. It can be, it doesn't have to be. Financial net worth and income for VA purposes. That's what the IVAT stands for. So now I've talked about the service requirements, talked about the medical requirements. The financial requirements are the toughest ones. We're going to get to them in just a second. Quickly here, your wartime eligibility period. If you Google VA wartime eligibility, this will always pop up. I go and check every time because although I have the years memorized and the months generally memorized, every once in a while I forget it was at May 7th, April 5th, and so I want to look at it. Look at it every single time. The dates matter. And if they don't have a wartime service date on the non-service connected, you're out of luck. Remember, that only applies to non-service connected. Service connected, it doesn't matter when you served. All right, I got 10 minutes left. Let's see how I can do this. Net worth. So they have a cap, the 2020 cap, $129,094. If you have below that, and your home doesn't count, as long as your home is on a lot size less than 2 acres, you're fine. If it's above that, well, there's a lot more calculation that goes into it, and there are some exceptions. But that's what you can have in the bank. It used to be prior to October of 2018, you could just transfer money away. Unlike TCAD that I was talking about, you could literally write a check to your kids and there was no penalty. But the VA finally decided, you know what, we think too many people are taking advantage of that rule. So they implemented a 3-year look-back clock, and they have a penalty divisor, which unfortunately is much smaller than what the TCAD penalty divisor is. And so small transfers of wealth can make very large penalties very quickly if you're not careful. Then you have your IVAP. And so your IVAP is your income for VA purposes. It's going to be all the income. If you're a married couple, that's Social Security for both husband and wife, that's pension for both husband and wife, that's RMDs for both husband and wife. And then they subtract out your unreimbursed medical expenses. And the goal would be in planning to maximize the pension to have that number equal 0. If your IVAP equals 0, then you are going to max out at the pension. And what does maxing out look like? Well, these are the pension rates. So if you're a married veteran and you need aid and attendance, you can get up to $2,266 a month. If you're a single veteran and need aid and attendance, $1,911. If you're a surviving spouse, $1,228. I'm not going to belabor the table, but you can kind of see, especially if you're a married veteran, you're looking at $25,000, $26,000 a year in supplemental income to help cover these costs. That is a very big deal, and it is a great program for veterans who qualify. And the sad part is not a lot of people know about it, and so the goal is to get the word out there. If they've served 90 days, have an honorable or don't have a dishonorable discharge, and they have high medical costs, i.e. living in an assisted living facility, needing help with activities of daily living, they are really worthy of sending in an application by a VA accredited agent or a VA accredited attorney. If you are not VA accredited, you are not supposed to help on these. The only exception is if you are a close family member, a husband can help a wife, vice versa. But for the most part, it is such a Byzantine process. I always tell people, bring in an expert to get it done. So I went over this. It determines your mapper. Let's say your IVAP is $1,000. And so I'm a married veteran and I need aid and attendance, and I was eligible for $2,266, and my income for VA purposes is $1,000 in the positive, which means I have maybe $4,000 in income and $3,000 in unreimbursed medical expenses. It is going to give me, the VA is going to give me $1,266, and I'll get what's called a partial pension, because what they're trying to do is give you a floor. And so they say, well, you're already netting 1,000, so we're going to give you what supplements up to 2266. Now, if your IVAP is a negative number, they're not going to give you more than that. That's a maximum pension rate, those numbers on the chart there prior. And so it doesn't behoove you to run up medical costs for obvious reasons. Now, unreimbursed medical expenses, I talked about that. Negative IVAP doesn't reduce net worth. Regularly recurring unreimbursed medical expenses is what they're looking for. So one-time costs you can submit a claim for at the end of the year, but what they are looking for is medical costs, you know, your insurance costs. If you have a regular treatment that you get all the time, you can try and submit prescriptions if you're getting them all the time. But the big ones you're looking for are care facilities, assisted living, memory care, nursing home care. Common questions and concerns. You're married, you're treated as a single unit for income and for costs. It can cut both ways, but it's generally a good thing. Claimant has a joint account. This is one of those exceptions. If you can demonstrate to the VA that the child has contributed a lot of money to that account, you might be able to get it counted in half, but the odds are they're going to count the whole amount. You can see that note on there. If there's a divorce, doesn't generally affect the veteran for benefits, but the spouse, the non-veteran spouse, oftentimes divorce, there are very unique and kind of detailed exceptions. What I always say is the rule of thumb is divorce probably severs the benefits. You can see some general exceptions. If the divorce wasn't valid, if it was caused by physical or mental abuse, or the veteran abandoned their spouse, you have possibly a claim with the VA. My saying always goes, if you're explaining, you're losing. So here are some of the kind of unique carve outs for people who are divorced or remarried, or if a veteran passed away and then you get remarried. And what I always, again, I could do 2 hours on the statute that covers all this divorce and passing away and remarriage. I will tell you, every time I get one of these, I go straight back to the statute every single time. It's that complicated. And I go through and I read it once and I read it again to make sure I'm analyzing it correctly. Again, why you need a VA accredited person. It's not that you are completely out of luck if you have a divorce or if you have a remarriage. It's that it needs to be looked at and analyzed very closely to get to the proper result. 3-year look back and penalty period doesn't apply to any transfers before 18 October 2018, only penalizes covered assets. Your home is not a covered asset. You can transfer your home, unlike with TinCare, with the VA, you can transfer your home without penalty, unless it's over 2 acres, and then there's going to be some math that needs to be done on what part is penalizable. And so penalty commences from the first of the month, the following date. There's a 5-year cap on the penalty period, but let me caution you, there's a 5-year cap, but there's only a 3-year look back. So if you trigger a 5-year penalty, you have committed malpractice, because it would have been better just to wait the 3 years and on the 37th month apply, rather than applying and triggering a 5-year penalty and then having to wait 5 years. So anyone who tells you we're going to do this and it's going to create a 4-year or 5-year penalty period, they are handling it wrong. And again, why you need a VA accredited individual. You can cure gifts, you can give the money back, and you can transfer. If you can show that a transfer was due to fraud or unfair business practice, so you know, an annuity salesman or insurance salesman sold you a product that they said would work for the VA and it didn't, you can take that to the VA. Again, a very high bar. Usually you have to make a report to either the police or to the Better Business Bureau that says I was taken advantage of. Very difficult to do. Transfer to a trust established for a child incapable of support prior to age 18. The money can never revert to the veteran or the veteran's spouse. And then you can cure the gift, and you just do it within 60 days and notice of the penalty. Traps for the uninformed. Don't do multiple transfers within the 36-month look back. Homes on lots greater than 2 acres, annuity planning. Annuity planning is not good for the VA anymore. It's actually harsher than TCAD. And so it is not a good manner of planning. A lot of people would use it previously as, hey, this will work out real well. It's not an appropriate tool anymore for VA planning. Poorly drafted trusts that allow the grantor or grantor spouse to benefit directly from the trust. If you do that, the VA is going to count the entirety of the assets in the trust towards the veteran, and it'll most likely disqualify them. Aid and attendance. There's a 2680 workbook, and I'm coming up. I'm going to get just under the wire. I always go over this. This is very important. When you're taking that form to your doctor, it needs to be accurate and comprehensive. What I do is schedule 2 appointments back to back so the doctor isn't rushed, the nurse practitioner isn't rushed. There is a lot of white space on the form, and there are lots of yes/no check boxes, but then there's room to write next to it. What did my old English teacher used to tell us? I can't read between the lines if there aren't lines to read between. Have the doctor write everything in they can write in. Remember, pass, fail on activities of daily living. If you have limitations, they need to be highlighted. The doctor needs to put those limitations up front. This is what they cannot do. This is why they cannot do it. Ensure the writing is legible. Seems obvious, but we all know that both doctors and lawyers, we're not known for our penmanship all the time. If they can't read it, it's not going to help you. All the info in the world doesn't do any good if it's in hieroglyphics. If incontinence is an issue, be sure it's addressed. I highlight that because no one likes to talk about that, and people hide that. That is not something to be hidden. That is a very key and important fact that the VA will need to know in making their determination. Be there with the medical provider, if your parent's getting this filled out, because parents will say, yeah, no, I know, I'm going to go in there. Then they go into the doctor's office with just them and the doctor and say, Doc, I'm fine. My kids are worried about nothing. You got to be there and make sure everything is covered. And then having a conversation with the appropriateness of a fiduciary. If mom or dad cannot manage their own financial affairs, the VA will appoint a fiduciary. It's another tool. It's good for some, not good for others. Get it right the first time. Stay on top of it. Bring in a professional. The VA process can go very quickly when it's done right. We actually had one approved in, I think it was 5 or 6 days. It's almost unheard of when everything's done right, but it can also languish for a year or two. We all hear those horror stories, and a lot of that hinges upon getting the application correct the first time you submit it. Don't have any issues, and it generally goes through much faster. Now's not the time for doing it yourself. Between TCAD, between the VA, you need professionals who understand the rules, who understand how to apply the rules to your specific circumstances to put you in the most advantageous financial position possible. Some key don't do just in general with estate planning. Don't do co-powers of attorney or co-trustees. If they disagree, you can kind of freeze the power, which isn't a good thing. This is not a democracy. Every ship has one captain. Put one person in charge. Don't use forms off the internet. Again, you need your plan tailored to your specific circumstances. What's good for your neighbor down the street isn't necessarily good for you. Avoid conservatorships if possible, I should say at all costs. Don't just give everything away to your kids, the purposeful pauper. That's not planning. I think that's dumb. Oh, I'm just going to give everything away and my kids will take care of me. We haven't mitigated your risk. That's not a good strategy. And don't attempt a VA application without a VA accredited attorney. And so I'll leave you with this. The best time to plant a tree was 20 years ago. The second best time is now. That goes with estate planning. It's best if you've had it taken care of and it's always been there ready for you if you needed it. But just because you haven't had it done up till now, it doesn't mean don't get it done immediately. Get it done as soon as possible so you're not worried. When you have a big life event, you don't want to be worried about the legal stuff. You don't want to be talking to the attorney. You want to be in the hospital with your loved one that's sick. You want to be with your loved ones grieving and taking care of the final arrangements for someone who's passed away, not going to the lawyer going, oh my goodness, what's going to happen because we didn't do this? That's not how you want things to go. You want to take care of the planning now so you can handle the really important stuff later, and that is being there for one another. Okay, I managed to get through all 40 slides. I'm going to open it up to questions. I know I'm right at the time limit, so let me turn it back over to the moderators and let them be in charge of what we can and can't do. But I will stay on the line here for anyone that has any questions.
If anyone has any questions for Chris, feel free to go ahead and unmute yourself and ask, or ask in the chat box and I can relay the message. But thank you so much, Chris, for this presentation. It was wonderful.
Oh, good. I'm glad. It's a lot of information. I know I go quickly. We want to hit as much as we can.
Yes, definitely. And I'll make sure to provide the PowerPoint to all the participants today, so you should receive a copy of it in your emails.
Okay, and I just popped open the chat box, and I'm seeing some questions. Let me see if I can, do you have income and or age limits for the folks you can help free of charge? It is, everybody's unique, and so I can't just give a blanket, income or age limit. No, what I would suggest is anyone who needs our planning, call our phone number. We have a very thorough intake process. Tell them to be prepared to spend 20, 25 minutes on the phone. We go over very in-depth. So A, we ensure that someone who actually is coming into our offices, there's someone that we can help. And B, if there's someone who needs something else other than our firm, that we can vector them in the right direction, because that's half the battle too. It's, if someone has an issue that's not in our lane, if you will, we want to get them to someone whose lane that is and make sure they're taken care of. So that covers that. Let's see. You do not recommend co-powers of attorney. Does that apply to healthcare? Yes, exact same reason. If I have brother and sister and they don't see eye to eye on something and I make them co-powers of attorney, and then they're in there with the doctor disagreeing on the treatment for mom, that power of attorney is no good, because the doctor, what are they, the medical professional, and rightfully so, this is not casting aspersions on them. They want legal certainty. They want to know that this is protecting them. Hey, the decision we made was in accordance with their wishes, and they assigned this agent who told us to do X, and that's where the liability lies. Well, if I have co-agents telling them different things, they're stuck, and it puts the medical professional in a very bad position. It's unfair to them. It's not good for you, because now your decision making, we often know in medicine that time is very critical in a lot of events, and we want those decisions made in a timely manner. And having them disagree on things is not good. And what I always tell them, if you want to treat the kids equal, make one the financial power of attorney and the other the healthcare power of attorney. There's plenty of jobs to go around: successor trustee, personal representative in the will. Sometimes I have families who just make the eldest kid primary and then right down the line, and I have some families who every child gets a job. There's no right or wrong answer. The right answer is what works for best for your family. And then let's see. Those were the two questions I saw. If there's another one, let me know. I'm very honored to have been invited to speak here. I know the wonderful work that you all do all during this time. We appreciate it greatly. I hope this helped elevate your abilities in the clientele that you work with, to help point them in the right direction. Most often, the biggest obstacle, especially to seniors out there, is just not knowing where to go, not having the information about what I need to have looked at or what the appropriate path is for me. Because once you get them to the right person, things fall in place very quickly. But that's often a very big impediment. And I know you guys see it as you guys are fighting through all the misinformation out there. So I'm very glad to have been invited and be able to share this with all of you. And yes, I will give Josh a hard time. Thank you for that comment. I feel like I have permission to do that now.
Yeah, Chris, that can come from all of us. Please give Josh a hard time, and please do give him a genuine hello and well wishes from us, though.
Absolutely, absolutely. And I saw the message from Elder Law East Tennessee out there in Knoxville. Great to see you guys here. And you can always call. I'm always happy to chat with people. And you know, if you need to talk to me, I love reaching out to the community. It's one of my favorite things to do.
All righty. Well, thank you again, Chris, for coming and presenting here with us today. We really do appreciate you.
You got it. You guys have a wonderful day. Enjoy your week.
Thank you. You as well.
Thank you.
And
Bye.
to everyone else, we're going to go ahead and start our lunch break now. If you're interested in doing the yoga session with us at 1 o'clock, please come back then. If not, we are going to start with our Smile on 60 Plus presentation at 1:15. So yeah, feel free to have a nice lunch, get a good stretch in, and I'll meet you guys for yoga at 1 o'clock. All right. Nicki Raines is the lead community dental health coordinator for Smile on 60 Plus and covers the Middle Tennessee area at Interfaith Dental Clinic. She has been a dental hygienist for over 30 years. She holds degrees from Tennessee State University in dental hygiene and psychology. During her career, she has served in many areas, such as a dental hygienist in private practice, dental hygiene educator, board member with Smiles for Lifetime Foundation, past president of Nashville Area Dental Hygiene Society, and a member of that board for over 6 years, and as the Southeast Regional Coordinator for the Oral Cancer Foundation. She enjoys traveling, gardening, and spending time with her family and friends, and of course, her beloved boxer. Let's all give a hand to Ms. Nicki Raines. And I will go ahead and start sharing her presentation.
All right. Thank you, Olayinka. So you're going to share the screen for me and advance the slides. So thank you, everyone, for allowing me to share with you today. And Olayinka, thank you for that introduction. And so my role with Smile on 60 Plus is I actually work as a lead community dental health coordinator for our program. So what I'd like to do, and I'm just really excited to be a part of the team. We, all the CDHCs are now certified level 3 ship navigators. So we're learning, and we appreciate being a part of this team, and just super excited to be presenting and sharing some information with you. So today my goal is to share with you just some current stats in the state of Tennessee that in relation for oral health for older adults. We're going to look at how does oral health play a part of overall health. I'm going to talk about Smile on 60 Plus, that program, give you some information on that, and also how you can help as a ship navigator. Next slide, please. So just to kind of share with you, Oral Health America did a report called The State of Decay back in 2018. And basically what they did is they looked at all 50 states, and there were several variables that they used to rank the states on how well each state was taking care of their seniors concerning their oral health. Number 1 was the very best in the nation. Number 50 was the worst. So in the chat box real quick, where do you think Tennessee landed? 1 being the very best and 50 being the worst. Where do you think Tennessee may have landed in that report from Oral Health America, State of Decay? All right, I'm seeing lots of 48s, 42, 33, 40. Actually, we ranked 49th. And as a dental hygienist, I've been a hygienist with over 30 years. That surprised me. It just really surprised me. So we as Tennesseans, we have some work to do. So just as this screen shows you that 34% of seniors in the state of Tennessee have had all their teeth extracted. 34%. 27% of adults have untreated decay. We know that Tennessee is one of 3 states that does not offer adult Medicaid dental coverage. These are some stats from the CDC. Back in 2014, we had more than 88,000 ER visits. Now, I can assure you that number is much greater today. And also the CDC in 2015 found that we had more than 1,000 new cases of oral cancer in Tennessee. So, as we all know that Medicare is the national health insurance for older adults, does not cover routine dental care, and the majority of people on Medicare have no dental coverage at all. As Ryan stated at the beginning of this conference, there's over 37.5 million enrolled in original Medicare. So those enrollees in Tennessee will have no coverage. Next slide, please. So, yes. What happens? Yeah, right there. Thank you. What happens in your mouth doesn't stay in your mouth. Now, if there's one thing I want you to remember from today is this slide. So that oral health is the foundation for overall health. Okay. And, what we know that oral health just doesn't impact your physical health. It impacts the quality of your life. So if you had missing teeth, imagine how you might be embarrassed and how that may affect your relationships with your family, with your friends, with your community, how that could lead to pain, how that could lead to embarrassment and to isolation. So what we know is that untreated oral health problems can lead to serious health complications. Next slide, please. So untreated caries, that's cavities, dental decay, and periodontal disease, which is gum disease, can exacerbate certain diseases such as diabetes, cardiovascular disease, can lead to chronic pain, infections, and loss of teeth. What we know, if someone's experiencing periodontal disease, that's advanced gum disease, that they're going to have an associated increased risk for cardiovascular disease. That can include a higher risk for stroke. If you have untreated oral health issues, this can also contribute to poor glycemic control with your diabetes. And the obvious, if you have natural missing teeth, or if you have no teeth, that can cause nutritional issues and relates to health problems. Next slide, please. So this is one thing I want to share with you. This information is from the CDC and the Kaiser Family Foundation, an article called Drilling Down on Dental Coverage and Costs for Medicare Benefits. And basically, and this is looking at the nation as a whole, but 1 in 5 adults have untreated tooth decay. 68% of older adults have gum disease. That's 68%. 1 in 5 older adults have lost all their teeth. 65% of Medicare beneficiaries don't have any form of dental coverage, and that's 2/3. And then among the Medicare beneficiaries that use dental services, the average out-of-pocket cost for dental care was $922. And then every year, more than 200 million people visit the emergency room due to an oral health issue. Next slide, please. So even within our program of Smile On, we are finishing up our 2nd year. And so we've been collecting data. And so out of our 2 years of serving Tennessee seniors, 84% of our Smile On patients have cited that dental cost or lack of insurance is a reason for not seeking regular dental care. There's other barriers too, like transportation and things like that. But we do know the biggest barrier is cost or lack of dental insurance. Next slide, please. So what we know is that seniors are not being proactive with their dental care. So that's simply due to cost or no dental coverage. So I want to just kind of share with you a little bit about our program, Smile on 60 Plus, and what we're doing. So just a couple of things. We are statewide. We have 19 clinics with 28 sites, and we have a goal of improving the oral health and overall health of Tennessee seniors that are low income and dentally uninsured. To be eligible for our program, you must be a Tennessee resident, you must be 60 years or older, you have to be experiencing household poverty level at 200%, and that's based on current year data. That would be like for a household of one, that'd be a salary of $25,525. I believe that's that figure. You have to be dentally uninsured, and if you are eligible and in the program, you pay a $25 copay to the partner clinic. So you now may be asking, well, if you are eligible and you're in the program, what does it cover? And so it basically covers all preventive, emergent, and basic restorative procedures, along with partials and dentures. And so by preventive, I mean that's exams and that's cleanings and x-rays. Emergent would be if it's an emergency visit, extractions are needed, oral surgery, if fillings are needed, that's covered. Partials and dentures, those things are covered. Things that are not covered would be a root canal, a crown, an implant, and in-hospital dentistry. Other things that we do, especially as a community dental health coordinator, we are out, actually before pre-COVID, we were out in the community meeting seniors where they were. So at the senior centers, we provided education, and everyone that attended one of our workshops actually received a free oral hygiene kit. We actually help with the transportation voucher if that is a barrier that's keeping a senior from initially going to a dental office, or if they're canceling appointments because they're having issues. We're able to work with various factors in helping them with that. We do case management, and I think that's been one of it's the best thing with the community dental health coordinators. We're able to help the seniors kind of navigate through this system. Sometimes just finding out first, are you eligible, and how to get to a partner clinic. And sometimes it's something as simple as getting in touch with the office. I don't know about you all, but sometimes you run into these phone systems. Press 1 for this, press 2 for that. And, there's a lot of patients that call me to let me know that they're going to be late, but they can't get in touch with the office and those kind of things. Or if they've had an emergency and can't get in touch with a clinic, we're able to help them through that. Next slide, please. And so just to remind you, our grant program is funded by the Senior Trust Elder Trust Settlement. And the administration of this grant is overseen by TCAD, the Tennessee Commission on Aging and Disability. We were awarded the dental health area. Interfaith Dental Clinic is the lead agency, and Smile on 60 Plus is the program that is statewide. Next slide, please. So we have 5 goals for the state of Tennessee with our program. So we want to be able to educate older adults in Tennessee on the importance of oral health across the lifespan. We want to control and or prevent oral infections in older adults. We want to correct oral conditions that prevent an older adult from eating or from smiling, which can lead to depression or isolation. We want to help a senior find that dental home. So if there is an emergency, you can go to your dental home, go to your dental clinic, and not the ER. We want to be able to help increase our dental providers, their knowledge and their education on caring for the older populations to improve outcomes. Next slide, please. So part of our process is we're providing education and resources. And, just like to your group as ship navigators, me being able to share this information with you today, we have materials that can help you help others that you serve. So we work, we may be at a senior center presenting to you as a group of ship navigators, different faith communities, churches, things like that, media outlets. We do workshops out in the community. Our community dental health coordinators are there in the community providing education and navigation. We have a hotline that our seniors can call and find out more information about. Next slide, please. And I mentioned this currently, before, but currently we have 19 clinics statewide with 29 sites. So we have 19 clinics with 29 sites. To date, these numbers are through July of 22, so there's actually more updated information, but we have served more than 4,656 unique patients have been cared through our program. And we've had more than 35,710 direct encounters. And direct encounters may be someone that's called our hotline, someone that showed up at one of our educational events. Next slide, please. So this is just one of our cute patients, Miss Douglas, just kind of showing, she already has a great smile that you can see, but after going through some dental work, it seems like her smile is even brighter, and she gets lots of compliments, and she herself just enjoys smiling. So next slide, please. And this is another one of our patients that we've served, Miss Hambry, and she actually hadn't been to the dentist in, around 15 years, and she didn't have dental insurance, and the cost was not in her budget. And she actually made an appointment with one of our partner clinics, but she was just there to have one tooth extracted. She just didn't know or didn't feel like she could afford comprehensive care. So she ended up being eligible for the program, learned about the program, being eligible for the program, and you can see how the dentist was able to restore her smile. I believe she was put into a new lower denture, all of her teeth were restored, and a new upper partial, and you can just see a huge difference in her smile. It truly, at Interfaith, our logo is a smile changes everything, and I truly believe that a smile does change everything. Next slide, please. So, and what you can, this is our information. We have a hotline, which that is 1-800-509-6055, and a website. And we have information that'll be going out to you that's going to give you our regional clinics in the West Tennessee, East Tennessee, and of course here in Middle Tennessee. And you'll also be able to have the community dental health coordinator that's in your region, their contact information. So you'll have their personal number and email. Now, one thing you can do if you have a client that you run across someone that might be interested, it's just as easy to give them the hotline, because our hotline will do a pre-screening, and that's to check to see if they're eligible and help kind of find the closest clinic to them. But you all know us now, the community dental health coordinator, so now you have a connection with us too. Next slide, please. So you may be asking, like, so how can you help? I think maybe there's a couple of things. It's just have an awareness. So when you are sitting down and working with your clients on trying to help them navigate through which Medicare plan may be best, just have a question maybe, what is your current oral health? And, do you have any possible needs for upcoming? Some of the questions that we actually use in our program is just asking a patient simply, are you limited in what you can eat? And if someone says yes, then you know right away that they're going to need dental care. Another question is the condition of your mouth, is it good, fair, or poor? And that information is going to help you know how to help someone. And a third question is, has the appearance of your mouth or teeth affected your quality of your life? And if someone answers yes on that, then then you know that they're going to need probably more dental care. And then the other thing is just an awareness of the cost of dental care. And this is kind of a hard area to kind of explain, and because it depends on where you live and who your dentist is, what these ranges are. But just to give you all some information, let's say if someone needed full upper and lower dentures. Now there again, it depends on where you live, what area of Tennessee, and who your dentist is. But that's a huge range, and that honestly can range anywhere from $3,000 to $4,000. Now you may be able to even get this a little bit less expensive at a affordable dentures. You know, that could be something. I'm not exactly sure of that cost, but it could be something even, you know, around $2,000. So the fees across the state vary greatly, just like for a cleaning. Now, the average cost of a cleaning and an exam can typically cost $100 to $150. An extraction, if you have to have a tooth extracted, that cost, now that can vary too, because it depends on the complication of that, extracting that tooth. But that can easily be from anywhere from $100 to $300. So you can see if you're working with a patient and trying to, you know, navigate them and help them with their dental concerns, a plan that has $1,000, that sounds like, you know, it's could meet a lot of needs. But we know that if dentures are needed, you know, perhaps is that the best plan? And it may still be the best plan, because that gets a little, even in private insurance, if you're working and have private insurance, typically those benefits are $1,000 to $1,500 per year too. Now, what I would like to do is just remind you, we're going to be sending out some information that has our clinics, contact information, and frequently asked questions about our programs, just to remind you about eligibility, and if someone's eligible, maybe how to get them help. Like I said, you have my contact information, you have our 1-800, our website, and you're going to have each of the community dental health coordinators contact information. We have Kim that's in West Tennessee, we have Brittany in East Tennessee, and then Lindsay is in Southern Middle Tennessee. And I'm Nicki, and I'm here in Middle Tennessee. So what I'd like to do is just open up for some questions. You can put those in the chat box. And let's see if I can answer those for you. Let's see here. Okay, I'm looking at a couple. So it says, my residents love the Smile on 60 Plus program. Do I still need to use the application for referral, or just give them the contact number? Well, that's a good question, because it depends on maybe where you live and what clinic. All our clinics are a little bit different. I know for sure the first thing I would do is give them the 1-800 number. Our 1-800 number should be able to answer most questions. You have me and all the other CDHCs too to rely back on if you have any issues, or once your client calls that 1-800 number and has any issues. Like one of our partner clinics, our lead agency, Interfaith Dental, actually requires their applicants to send in an application along with documents, and therefore they review this and go over it before the senior arrives, just to make sure there's no surprises. And every clinic is a little bit different. I hope I answered that one correctly on that. Let's see here. Where's Smile On located in Northwest Tennessee? We have a clinic there in the Reelfoot Lake area. And Kim, I don't know if you're on here. Give us more information about Reelfoot real quick. I don't have it in front of me, unfortunately.
Sure. Can everyone hear me?
Yes.
Okay. I'm Kim. I'm the West Tennessee Community Dental Health Coordinator, And we do have a clinic at Reelfoot. For those of you who are familiar with Reelfoot Lake, it's about 10 minutes. It's in Obion County. And Brandy is the contact person at that clinic. And we also have Church Health here in Memphis and Christ Community Centers here in Memphis, Tennessee.
Thank you, Kim. Also, there's a question on here that says, I didn't see a site in the Jackson, rural West Tennessee area. You're correct. Unfortunately, we have some big gaping holes in this. In our Upper Cumberland, we have some holes in West Tennessee. Now, so the folks in Jackson would have to travel either into Memphis area or into I don't know. That's a big hole right there. I'm sorry about that. So, and then too now, and I want to remind you, you're going to be getting a resource that's going to list every one of our clinics and exactly where they are also. So basically, if you're in Jackson County, unfortunately, it's going to be Memphis, or it's going to be the Reelfoot, or it's going to be Middle Tennessee. And that's quite a gaping hole, I know. Someone asked here, how does this work with dental coverage in a Medicare Advantage plan? So that's a great question. And most of the Medicare Advantage plans will have dental coverage. Now, you all are much more experts than I am at this, but what I have found that this coverage ranges anywhere from a couple $100 to several $1,000s. But basically, so it gets a little difficult, and that's why we always ask patients to present their insurance card, their Medicare card, their Advantage or supplemental card, so that it can be reviewed. We've done a lot of research to help our partner clinics know what plans may have insurance and what those look like. So basically, if they have insurance through an Advantage plan, typically they are not covered under the grant program, because this grant is designed for seniors that are uninsured. Just kind of checking to see if I've answered everything. So something about Memphis, we do have lots of several clinics there in the Memphis area. That is Kim's area also. How long is the grant for? So we are finishing up our second year come mid-October. And the grant is funded for 3 years. We know there will be perhaps some type of an extension due to COVID. When COVID hit, a lot of our clinics had to actually close, and they were not able to provide care for weeks, and for some clinics, even months. So we do expect some type of extension for this program, but however, we don't know the details of that at this time. Any other questions? And did I skip any questions that I needed to answer? I think I answered that one.
Hey, Nicki, there was a question asking about the pre-screening process and how detailed the financial eligibility questions are.
So, so the question is, what does that pre-screening look like, and what needs to be what needs to be presented to find out if you're eligible? So pre-screening, so one thing, like let's say if it's our hotline or if I'm talking with a patient, I'm going to verbally go over a few things, and what I need to know is that you're not dentally insured, that your household income is within that 200% poverty level, and that you're a Tennessee resident and 60 years or older. While we're on the phone, or that's presumptive eligibility. Now, documents must be presented to the clinic to confirm eligibility. So typically what someone is sending in is their Tennessee driver's license or Tennessee ID, which has their date of birth on it, that shows they're 60 or older, that shows their residency of Tennessee. Usually a copy of an insurance card is requested, and that is whether it's your original Medicare or your supplemental or an Advantage plan. And once that is reviewed, the clinic would be able to know if there is any type of dental insurance connected to that. And then the household income. And we're looking at, typically that's Social Security benefits. People can turn in, if they're still working, their last 2 pay stubs, or sometimes a bank account that has that Social Security deposit there. So those are the documents that are needed to confirm eligibility. What other questions might y'all have?
Is there a smiling program for people not over 60?
This program is just for adults that are 60 years and older. Now, there's different areas have different clinics that may be of help to different areas. It depends on where you live and those kind of things. There's safety net type clinics that can be based on income. And I can help get a resource out for that too. And that may be something that would be beneficial. Any other questions?
If there's no further questions, I want to go ahead and just thank you, Nicki, for coming and giving such a wonderful presentation. I know this is going to be very beneficial to our beneficiaries, and I know we all appreciate you coming out and talking to us.
Thank you. I appreciate you too.
Awesome. I don't think anyone has any other questions, so give me just 1 second and we can transition to our last portion. All right, everyone. So we're in our final section of today, our closing remarks and our regional breakout sessions. I just want to go ahead and say one more time how much all of us here at TCAD and all of your regional coordinators appreciate you and all of the work that you do. We truly would not be able to operate without the support of all of our fabulous volunteers, and I just want you to know that we are so thankful for you, especially in the time of COVID and the craziness that we have going on in the world. We really do appreciate each and every one of you so much. I'm now going to open up the floor for our regional coordinators to go ahead and give a few words about people on the spot. First and foremost, we have the Aging Commission of the Mid-South. They're going to say a few words about their volunteers, and we'll go through each region. And afterwards, we'll go ahead and split everyone up into breakout groups based on their regional, on their region. Okay, cool. If Marcus or Adrian, if you would like to go ahead and say a few words, the floor is yours. Just make sure to unmute yourself.
Hello?
We can hear you.
Okay. I just want to, first of all, just this past COVID-19 situation, what is the COVID-19 situation that we're encountering is kind of difficult, but to all the volunteers that have supported us and continue to help as we are able to provide services down here. They have been just super tremendous. The mail out, especially the last couple of weeks or so, the mail out has been just great, and their participation has been wonderful. And I just want to commend them and let them know I appreciate them. Ms. Franklin appreciates them, and they're doing a tremendous, tremendous job. And I can't say thanks enough. So we just appreciate them and want them to know that we're here for them just like they're here for us.
I concur. This is Adrienne. Sorry, it took me a moment. I had to get rid of Tupac in the background. I just want to agree with Marcus. We really do appreciate oh gosh. That I really do appreciate all of our volunteers and their help. And just to remind everyone, like Ryan said, we're not going to be able to do, the face-to-face counseling, but we have been getting some of those worksheets back. So, and we will be getting in touch with you all shortly, but just for those who want to, get a jump on it, if there's anything that you'd like to do, you're welcome to pick up materials, come by the office, whatever works for you. So just give us a shout out on email or on phone, and we'll be happy to just work and see what would be the best options. And that's all I got.
Oh, I want to add also, if I may. Hello?
Go ahead.
Yeah, I just want to once again encourage the volunteers. One of our volunteers lost her daughter a couple of weeks. Well, no, last week she lost her daughter, and the funeral services were last Friday. So all of the volunteers who, if you would just continue to just remember, Rose Benson, and give her an email every now and then, letting her know that you're thinking about it and praying with her and her family. Her daughter was eulogized on last Friday. So if you would do that, Ms. Franklin and myself would greatly appreciate it.
Wow, I'm so sorry to hear that. Thank you again, Marcus and Adrienne, for sharing all of that. We do appreciate y'all. Next up, we have East Tennessee AAAD. Go ahead and go.
Hi, it's Amanda. Y'all hear me?
Yes, ma'am.
It's Amanda. Can y'all hear me?
I can hear you. Can you hear us?
All right. I just wanted to, of course, thank you all. The work, we can say thank you millions of times, but that doesn't really emphasize what y'all do for the program. And I think a lot of the volunteers, y'all don't realize how important that you are. And not only to the SHIP program, but to all of the Medicare beneficiaries out here. So if it wasn't for you volunteers, we would not be able to reach all the beneficiaries that need services. Some of y'all really, really stepped up as far as data entry. I really appreciate those who help with the data, not only before COVID, but after COVID especially. We have a lot of data to input, and y'all doing that for us. You deserve a big thank you for that. Several of our volunteers are entering their own data now. That helps our staff out a bunch. We appreciate it. We would not be able to reach everybody if it wasn't for you all. When I took my maternity leave, I didn't have to worry. I didn't have to worry about, would Elizabeth and Lisa, would they be okay? Because y'all helped. Y'all helped. It took stress off of me. It took stress off of them. I mean, they are very appreciative for y'all helping while I was gone. Now I'm back. We've got this coronavirus going on. Y'all are still helping. We can see it in the monthly reports that you send. A lot of y'all send me emails asking questions. That just shows that you're working hard. So thank you. And like I said, I could say it a million times, but I really can't convey it in words. So if it wasn't for you volunteers, there really would. wouldn't be a SHIP program in my opinion, because we couldn't reach everybody. So thank you very much.
Thank you so much, Amanda, for sharing. Next up, we have Family and Children's Services. I want to make sure y'all are on. Let me know if you're on.
I'm here. Can you hear me?
Yes, can hear you loud and clear.
Oh, good. So this is Tina Fields, the volunteer coordinator for Family and Children's Services. And of course, we also have Sheila Stutz and Ms. Joyce Pirtle. And of course, we think our volunteers are the best of the best. I was very excited this year that we were given the opportunity to recognize as a group as well as individuals, because every year it's so difficult to pick just one person that does an exemplary job, because you all do. And so when I was thinking back and trying to figure out exactly what we needed to highlight amongst our volunteers, I wrote something down, and I'm just going to read it if that's okay. So I said, as we all know, our world turned on its head in March 2020. With the pandemic came fear and uncertainty. It was during this time that I was blessed to see an entirely different side of our volunteers. I knew each of you were kind and hardworking, but this was a different type of care. Via social media and reports from community members, I witnessed our volunteers extending comfort and prayers and assistance. There were numerous offers of, do you need anything? And what can I do for you? Though that work wasn't necessarily connected to the SHIP program, it was positive proof that our program contains the best of what our state has to offer. Prior to the required quarantine, and now that things have started to reopen, our volunteers are the first in line to help. Whether it's contacting a beneficiary with reassurance or placing stamps on an envelope, they see it as an opportunity to help. They always, they all maintain a desire to learn and then implement that knowledge. I once read a quote by Mr. Rogers. It said, "When I was a boy and I would see scary things in the news, my mother would say to me, 'Look for the helpers. You will always find people who are helping.' I'm so proud to work amongst such helpers and look forward to the future with each of you." I say it every year. It's amazing to me that we have people that are so selfless to give their time and their energy and ask so little in return. I think the program is amazing, but the volunteers are the reason behind that. Sorry, I'm losing my voice. So to each of the volunteers in the state, but especially to our Southwest volunteers, we thank you. We stand in awe of you, and we love you.
Beautifully put, Tina. So thank you for sharing. Thank you so much for sharing. Next, we have First Tennessee.
Good afternoon. This is Melody with First, and I just want to say a big thank you to all of our volunteers and really echo what everybody else has already said much more eloquently than I could have. I've been with SHIP for a long time now, and our volunteers are awesome. We have a lot of volunteers who are in-kind volunteers who do counseling, volunteer work as part of their regular jobs, and they work really hard to stay up to date on Medicare and make sure that the people that they're serving are getting the best information and getting all the assistance that they qualify for, and we really appreciate that. And we have other volunteers. We have one guy who's really like the guy in his community to go to for Medicare help. He does a great job, and we have volunteers who help us out a lot with administrative work and have been a huge help the last few months with entering our data and helping us get our mail outs out, which has been a big relief for me to and Harley to stay caught up and keep our heads above water. The volunteers, like other people have said, are really, I think, the biggest part of the program in making sure that we reach our beneficiaries and get them all the assistance that they need and understanding all of their Medicare. So I really say a big thank you. And I think that's all I had. Thank you.
Sorry, I forgot to unmute myself. Thank you so much, Melody. That was beautiful. Next up, we have GNRC.
Hi, this is Christine Mather. Good afternoon, everyone. It's so nice to at least sort of be here with you. I can't begin to express how important volunteers have been. And for GNRC, they've been absolutely vital because for a while there, you know, we have our wonderful Lori, and then she went on to doing great things at TCAD, and we didn't have her. So we had our wonderful volunteers who, with Rebecca Nofi and Shannon Llewellyn and Diane Schlafman, have been doing SHIP. They were SHIP. They were the ones doing all of the counseling. So that's just tremendous and amazing. And they've handled that extremely well. And they've handled COVID extremely well. And anything that we ask them to do, they do for us. I just want to express our boundless gratitude to them. During this time of transition, they've kept SHIP afloat. And whenever Medicare beneficiaries or SHIP have needed anything, they have stepped in. And Rebecca, Shay, myself, Diane, Shannon, we're just all so grateful for you. Thank you so much.
Thank you so much, Christine. Next, we have South Central. Share your mic. I think you both are on, but I'm going to give you just another moment to.
Can you hear me?
Yes, I can hear you now.
Okay. Hi, everyone. This is Mike. Let me begin by saying how privileged we are to have the caliber of volunteers in the South Central Tennessee District. Several of our volunteers have been in the SHIP SMP program since 2009. That's 11 years of continuous service. We even have a few that joined us this current year of change. Many of our volunteers are true volunteers. They have retired from their chosen profession and are now helping those in their communities who have Medicare issues. These volunteers are very dedicated and go above and beyond. For example, they do follow-up calls to make sure clients receive the QMB, SLMB, or LIS they help them apply for. The South Central District covers 13 counties. These counties are spread out from Perry County in the west to Franklin and Coffee counties in the east. The driving distance is about 130 miles. Time-wise, from one end of the district to the other is around 3 hours one way. Staff alone could not cover this huge geographic area. In addition, since the volunteers cover the areas they are familiar with, they know about local events and useful locations. We cannot leave out our in-kind volunteers with the South Central Human Resource Agency. They screen their clients for help with Medicare costs and issues. They allow us to pass out SHIP, SMP information at their commodity events. I'll end by saying without our volunteers, the South Central District would have no SHIP program. So thank you, thank you, thank you.
Thank you so much, Mike, for sharing. Next, we have the Northwest Sorry, next we have Northwest with Ivy McDaniel. I think you were on. Sorry, I think Angela Ray is speaking, but I don't think we have her unmuted. Let me see if I can. Oops, okay. Well, we will come right back to Northwest. I think we're having a little bit of technical difficulty. Next, we have Southeast, and Southeast actually has a video prepared, so give me just one moment to bring that up.
Littered with thousands of starfish, beached and dying after a storm. A young man was picking them up and flinging them back into the ocean. Why do you bother? The old man scoffed. You are not saving enough to make a difference. The young man picked up another starfish and sent it spinning back to the water. Made a difference to that one, he said.
All right. Beautiful slideshow, or a beautiful video from Southeast. I think they would like to share a few more words, if I was correct. Marianne, you're on the line.
Well, you've got Helen. Will I do?
Yes, Helen, definitely.
Okay. Well, we appreciate all of our volunteers and we thank you. There's no way that we could do all we do without your help. And I want you to know you make a big difference. And we're looking forward to having lots of people talk with you on the phones this season as we get ready for open enrollment. We thank you, thank you, thank you.
Thank you so much for that, Helen. Next up, we have Upper Cumberland.
Hello, can everyone hear me?
Sure can.
Hey there, everybody. I'm Amanda Smith. I actually just started at the end of September as volunteer coordinator for the Upper Cumberland. And so I have been trying to get acquainted with all of our volunteers. And although I don't know everyone super closely yet, I still want to give a really big thank you to everybody. We have a good mixture of some in-kind volunteers as well as true volunteers who spend so much of their time helping us. Since we had so many different client contacts last year, there have been quite a lot of files to try and get organized and sorted out, and we've had some people able to help us get that done. So I want to say a huge thank you for that. And then I also want to give a big thank you just in general for our team of volunteers for being so willing to be cooperative and able to help out in any way possible. I don't know if I can very eloquently give a big thank you and just as much as everybody else has here, but the work that they do is so important for us and for everyone, especially for those people that are really just volunteering their time freely. That's really important. And so, yeah, just a big thank you and virtual warm hugs.
Yeah.
Thank you so much for that.
Can everybody hear me?
Yeah, we can hear you.
Oh yeah, just to reiterate what Amanda said, and this is Tyler McCullough with the Upper Cumberland. All of the volunteers play such a vital role in what we do. We have multiple volunteers that help come in and help file, help do data for us, help do the Part D comparisons for us every year, mail them back out. And we have ones that counsel on our level, make phone calls, do all the one-on-one counseling with new to Medicare's, host welcome Medicare classes. So we have so many volunteers of all varieties that really play a major part in what we do. And Upper Cumberland last year during open enrollment, we hit the $1 million mark in cost savings. And we wouldn't have been able to do that without each and every one of our volunteers. So just to reiterate what Amanda said, a huge thank you for everyone that plays a part in the Upper Cumberland region, and we certainly wouldn't be able to do it without you.
All right, Tyler and Amanda, thank you so much for sharing. Last but not least, we have Northwest. We're having a little bit of technical difficulties getting them in, so give me just one moment while I connect them. And Angela, if you're able, go ahead and talk. I'm trying to unmute a couple people to see if I can get you on here. All right. Angela, can you look?
Yes.
Okay, there we go.
Okay, finally. It wouldn't be 2020 if student didn't have a technical issue. Okay. First of all, Miss Ivy and I would like to thank all of our volunteers. We greatly appreciate you and all that you have done to make a difference in our region. Your generosity has had a profound and lasting impact on the beneficiaries that you have served. And we're amazed at your willingness to share both of your time and your talents by volunteering with our program. And it says a lot about yourself to give such selflessly to help others. And we are grateful for all of your support during this past year. As volunteers, you have helped us to reach out to more than 20,000 beneficiaries through outreach events and help us counsel over 5,800 beneficiaries in our region. And that allowed us to have more than $1 million of savings. We also appreciate your dedication through COVID-19. During this time, we have noticed all of you going above and beyond to continue providing much needed support to our at-risk population. I personally have noticed several of you stepping up to the plate to not only provide Medicare counseling, but to ensure individuals in our areas receive much needed assistance such as delivering meals to them, providing safe activities to help ease their loneliness, providing reassurance calls, and much more. While I know that you choose to volunteer and don't ask for recognition, we want to do that today. I want to let all of you know how much your dedication is appreciated and to make sure that we are forever grateful to each of you. Whether you are a longtime volunteer or if you got involved fairly recently, and regardless of how many hours you choose to give, it's important for you to know that what you do does make a difference.
Angela, thank you so much for sharing. I want to again thank all of our coordinators for speaking on behalf of all of your volunteers. It was just so wonderful to hear all of your different perspectives of your volunteers, and just it was great to hear.